with us, you'll find it a lot more valuable for the day as well. Over to Carleen.
Brilliant. So as we have you all here today, normally what we would do is we would ask you to introduce yourself into the chat. But as we have so many lovely QI enthusiasts with us, we thought we'd do something slightly different. So what we're going to do is a bit of a word cloud to see where you're signing on from. So Louis, if you would just launch the word cloud for me. Oh, or if you could just place in the chat where you are from, and then we'll be able to see where you're dialing in from today and make a note of that, and we'll do a little bit of a word cloud after. So just in the chat for us, if you could place where you are dialing in from today. Brilliant, we can see a range. Excellent, so we've got Brent here, we've got Gloucestershire, Wembley, Kent. Oh, quite a few. Harrow, we've got here. So quite a few from London. And quite, oh, Coventry, we have here. Cornwall, we have here. Westminster. So we have a really wide range. So thank you so much for coming along today. We hope that you enjoy this morning with us. So, Louis?
Trying to find my unmute button there. So yes, we are on Twitter today, guys. So please use the hashtag CLCHQI 2023 and also at CLCHQI. I have a bit of a background noise, so just make sure that you are muted. And feel free to put any questions in the chat. Of course, as I said, we do have our lovely assistants, Hannah and Carlos, who will be monitoring the chat this morning. So please do put in questions in the chat. Now what we're going to do is do a little bit of a warm-up, with this virtual environment, MS Teams. So if you have found the React button at the top of your screen, give it a little try. I want you to send a love heart. Can you send a love heart, everyone? Does that work? Great. So it does work. I can't see any on my screen. Great. Okay, I can't see them for some reason. Now try to send a clap emoji. Excellent. Oh, I'm hoping that works because I can see it on my screen. Great. Thank you. Great. Okay. Thanks for that. Let's start the conference, shall we? I think that's a good point to start. So I'd like to introduce James Benson, who is our Chief Executive Officer, to open today's conference. Over to James.
Thank you very much, and hello, colleagues. It is so lovely to see so many people here today. I'm just looking at the screen, we've got 130 people with us who are attending from across the health and care sector, as well as other specialties, service users and colleagues for our third QI conference.
Sorry, James, you're on mute? Oh.
I'm not on mute on my phone, on mine.
No, I can hear you, James, as well.
Yeah,
we can hear you
fine. Good, excellent. Great, thank you. It's always fun when it's like, oh, I'm randomly talking. So colleagues, a really big welcome. It is so wonderful to see so many people joining. We're now at 136 participants. I have the absolute pleasure of being the Chief Exec of Central London Community NHS Trust, CLCH, and we are one of the largest community trusts in the country, and we span 4 integrated care systems. We have a very, very large geographical area and provide services to our residents across 650 sites, plus in their own homes, which is 11 London boroughs, plus the entire county of Hertfordshire. And we employ over 4,500 staff. On a daily basis, we provide care and support to over 11,000 people a day. Our organisation has really been navigating its way through the challenges of the global pandemic, and particularly in restoring services and supporting our staff to work safely in a very different way, really focusing on what we can do to support the lives of our residents and reduce inequalities. We have built on the rapid progress we've made during this time to address these health inequalities and digital exclusion by delivering improved access to services through the safe use of technologies, and we've built on our QI capability of our staff through a trust-wide on-site QI training and support offer. Today, our conference is a really important chance for us to share our latest developments and best practice, and to use and improve the quality of the health and care system that we work in, both locally, regionally and nationally, and really understand our service users' perspectives. And I suspect there'll be an awful lot of debate generated from today. Over this year's conference, we will be hearing from John Ashcroft, the NHS England Director of Pathways. John will be presenting on the NHS impact and the future of improvements for the National Health Service. He will set out the genesis of NHS impact, its current plans, its future ambitions on behalf of NHS England. A significant piece of work that we have been leading on in collaboration with 23 other organisations is the Quality Coach Development Programme. This programme trains a small proportion of frontline staff within each pilot organisation in more advanced improvement concepts. Sid Beach, our QI training lead, will share with you what we have developed and delivered in this very exciting and groundbreaking programme. Following Sid, you're also going to hear from Elizabeth Hale and Jem Ramazagalu, our Director of Communication Improvement and our Quality Improvement Programme Manager, who will discuss how we're striving to make QI a part of our organisation's culture, continuing to build our QI capability as a trust, as well as trialling a quality management system approach to trust delivery of care. And this is going to be really important as we work with partners across healthcare and the voluntary system to understand how we deliver better outcomes for our residents. We all recognise that our frontline teams and our service users and our carers are often best placed to develop the solutions to today's needs. By allocating sufficient time and resources to quality improvement, which will include time for staff away from their usual day jobs to participate in quality improvement activities, we will address and deliver a key developed local solution to often what we describe as the wicked problems in our areas. Today, you'll be seeing some of those case studies, and I'd really encourage people to ask as many questions and be engaged as part of understanding what those case studies look like. But let us start our conference, and it was with absolute pleasure that I introduce our opening guest speaker today, John, who is our Director of Pathways for NHS England. So John, I'll hand over to you.
Hi, I'm Jodie. I work to John Ashcroft on NHS Impact. John is joining us. He had trouble just getting in on the link just moments ago, so he should be with us any moment now.
That's absolutely fine. Do you want to let me know when he comes in? I might just do a little filler in the gap.
Yeah, sure, okay. And if there's a bit longer, I will too. So just bear with us. Thank you.
That's absolutely fine. So today is really about us as we come out of a pandemic and really focusing on a different way of working as an organisation with partners, to really think through how we ensure that everything we do is always on a journey of improving the way health and care is delivered. I think over the coming years, we are going to see much greater partnerships between the NHS, local authorities, the voluntary sector, but in right of our residents. The reason that we exist as organisations and as health and care colleagues together particularly is to deliver outstanding care. And for me, as the Chief Exec and as a clinician, this has always been about how we improve. There are things that we could always do better within the resources that we've got. And I'd really encourage colleagues today who are in this conference to not only listen and learn, but to challenge and to think what sorts of things they can take back into their teams, into their communities, into their organisations to improve the way care is delivered and how they share that back with us as an organisation. As the Chief Exec, I'm absolutely committed to QI, and I think increasingly what we're going to see is that as we train more and more colleagues, we're going to get more and more challenge, and challenge is often a good thing. Challenge in the way we deliver services means that we're constantly focusing on what we can do and how we will reduce inequalities. And through COVID, we recognised that inequalities and inequality of outcome was writ large. And I understand from our Reducing Inequalities Task Force yesterday that our teams have been working on a very specific task to reduce those inequalities in terms of access. And they've been using significant QI methodologies to think through how best to deliver care moving forward.
James, I believe John has
John
just
managed
arrived.
to join us yet.
Yeah, I believe he's just joined.
Excellent. John, it's an absolute pleasure to welcome you to today's conference. As per usual time-honoured tradition, sometimes links don't work, but I've been setting out where this conference is going to and what we're hoping to get out of today. So I'd love to hand over to you to set out your vision for the NHS and specifically your work that you are leading.
Perfect. Thank you so much. Can everyone hear me all right? Yep, and I'm absolutely delighted not only to be here, that we can blame the link for me being 1 minute late rather than that being exclusively my fault. So thank you so much for having me. I will try and talk for about sort of 10 to 15 minutes maximum, so we've got time for a bit of conversation. But I'll start by introducing myself, if that's all right. So my name's John Ashcroft. I'm Director for NHS Improvement. Prior to that, I had the privilege of being chief exec of a couple of hospitals in Manchester. I was very lucky that we managed to get to CQC outstanding. Brilliant organisations, really lucky to work for them. And prior to that, I spent about 15 years working in and around London. So I worked in North Central London. So I'm absolutely delighted to be part of the sort of conference today, because I do have a huge amount of affection as well as respect for what you guys do. So just before I get into the slides, which hopefully someone will sort of put up, I'd just like to share with everyone something that happened to me on my second day as chief exec of Manchester Royal Eye Hospital. So on my second day, I had to attend a meeting with a family who'd been through a complaint investigation process, and effectively there was a gentleman, a very, very reasonable gentleman in the circumstances, who had glaucoma, which is an irreversible sight-threatening condition. He'd been diagnosed by us, he'd been put on follow-up waiting list for his treatment, and he had gone from having sort of 70% vision to perception of light only, because we had not seen him in a timely fashion. And effectively, through the way that we were sort of managing our processes, that we had caused a really sort of, a life altering degree of harm to that patient. And so I had thought I'd done stuff around quality improvement in previous roles, but really that was that really sobering experience of talking to that gentleman, talking to that family about their experience, about what we needed to do, about how effective this was sort of entirely avoidable, was really when I started to sort of genuinely learn about quality improvement. So following on from that, we spent quite a bit of time as an organisation investing in QI, applying it particularly to this issue. And I'm absolutely delighted that we moved from a position where we were having on average, when I started, 4 to 5 patients who were suffering some loss of visual impairment a month, purely down to our inability to sort of see them and follow them up and treat them appropriately, and down to that being 0.2 a month going forward. So we're not perfect, there's always more to do, but that is something that always stays with me, because I think it's really easy, particularly when you're sort of national roles that you guys are in, when you're looking at numbers and these are all people, and I often think back to that family. I can picture them all really, really clearly, and I think that is why we are doing this, and that is why QI is so important. Because I worked at other organisations where I think people think, oh, well, quality improvement isn't that, handing out an iPad to someone in an outpatient waiting room or something, as opposed to being, this is really fundamental to the way we improve care, we reduce inequalities, and we provide better outcomes for our patients. So I always think about that gentleman and that family when I'm talking about it, because it is really, really important to me in terms of what we do. So that's who I am. And so can I have the next slide, please? So first thing to say before we talk about the sort of review and what I did is to talk about the evidence base. So there is an evidence base, a strong and growing evidence base around provider organisations who systematically apply quality improvement, have better experience of care, they have better staff outcomes, they use their resources better. There isn't as much evidence for systems, but that is a growing body of evidence. But I thought it was really important that we just sort of ground the conversation, saying this isn't a sort of nice to do, this is evidence-based in the spirit of sort of continuous improvement. This is evidence-based, there is an evidence base, and we are continuing to grow and build it as part of the work that we are doing. So if we could have the next slide, please. So Anne Eden, who some of you may know, who's the regional director for the South East, was commissioned by Amanda to do a review about how we do improvement as the NHS, engaged with over 1,000 people, patients, clinicians, lived experience partners, and we involved local government, over I think about a 12-month period to look at what do we know about how the NHS does improvement and what can we do better, and all in the service of having better outcomes for our patients, better access for our patients, reducing inequalities, and making best use of the resources we've got available. So if we go to the next slide, in February of this year, the board endorsed 3 actions which came out of the review. The first was to launch a single shared NHS improvement approach, which is NHS Impact. The second was that the National Improvement Board agreed a small number of national priorities, and we established the Improvement Board, which I'll talk about a little bit later, and that we co-design and establish a leadership for improvement programme as well. So the board endorsed this. Go to the next slide, please. And on the 19th of April, Amanda launched NHS Impact. So what NHS Impact isn't is saying that everybody has to use exactly the same sort of methodology or approach. It is just the principle that every organisation in the NHS should have an approach to continuous improvement, that we should be aiming to move towards having an embedded, mature management system around this. 5 components of NHS Impact, and based on all the evidence, which I'm sure will be familiar to loads of people on the call, about having a shared purpose and vision, investing in people and culture, developing leadership behaviours, improving our capability and capacity, and embedding improvement. And one of the things that I think is different about NHS Impact than around, I think, some other attempts that we've had to do this. I know the NHS Improvement a number of years ago did a sort of similar review. I think is about Amanda's absolute clarity about this being mainstreamed and not being seen as another thing, but about this being the way that we do our work. So if we could have the next slide, please. So I won't go through the detail, but someone will pop in the chat a link to the website, which is open access. You don't need to register. That has all this detail on. When Amanda launched it to the trust and system chief execs, we took a bit of time to sort of ask them what would need to be true for you and your organisation to increase their sort of capability, capacity to really sort of embed this. And there were a lot of really honest and thoughtful conversations that sort of came about. And a number of things that were sort of shared with us were about, number one, well, NHS England really needs to role model this. And we need to be walking the walk as well as, the way we operate at the minute. Second was that we need to use data differently. So I think we're often very guilty, certainly nationally, of doing sort of snapshot reports rather than looking at our data and visualizing it in time series to really demonstrate improvement. I'm sure many people on this call have been in that position where you might have a phone call from someone in NHS England saying, well, your performance was terrible today. What's all that about? And you might say, but actually, that's just standard variation. We're actually on a sort of upward trend. We heard a lot about understanding that every organisation's in a different starting place, and that we need to be making sure we've got tailored support them to do that. And there was also a request for a jargon-free self-assessment that organisations could use if they haven't begun this journey. So we did try and begin as we want to go on, in terms of being really curious and sort of co-producing what the actual national programme around NHS Impact needs to look like. So if we could have the next slide, please. So National Improvement Board, and we're hoping it will meet for the first time in September. We are hoping that we'll be making an announcement early next week about who the chair and deputy chair of that board will be, because we have been through a recruitment process, and we are going to be going through a process of recruiting a national clinical director, and also looking for, I think, an improvement director as well. So that will be coming out shortly. And again, I think that Amanda's really clear that we're going to have a national improvement board that will report to her executive committee, so that this is mainstreamed and this isn't seen as a sort of a nice to do. This is going to be core to how we deliver some of the really significant challenges that we as the NHS are facing at the minute. Can I have the next slide, please? So in terms of the Leadership for Improvement programme, that is coming soon. I think it's likely to be October when we might hear a bit more about it, but the Workforce Education and Training team, we're working very closely with them about that. And I think taking some of the learning from things like the Modernisation Agency around the amount of time and energy that was put into, you know, ensuring clinical engagement. But I think one of the reflections from people who worked on the Modernisation Agency was probably we didn't spend enough time with sort of boards and chief execs, chairs and NEDs to make sure that we had the right conditions for the organisation to really progress with their work. So that'll be coming shortly. I think the next slide is a link to the website, which is going in the chat. We've got an email address if anyone's got any questions or queries or wants to get involved. At the minute, so as I said, the website is open access. We are in the process. We've got an ambition to move to this being the single place where we have all of our high quality materials in a single place that's open access, because I know a lot of people tell me how frustrating NHS Futures is with the sort of multiple passwords, and there's good information on there, there's good communities of practice, but it's quite difficult to sometimes get to the material on there. So I'd encourage everyone to go and look at the website, and some of the slides that I've used are under the delivery and continuous improvement review section. And I think that is probably it in terms of the slides, if I'm not mistaken. So yeah, so as I said, I think that there's going to be some communication early next week, probably coming out from Dr. Vinter Walker, who's the lead for this. And at the first National Improvement Board, one of the things we want to do is to actually understand where we are, because I don't think we have a baseline, or we've done a needs analysis. So we are going to be communicating out with a set of questions that we've co-produced with regional, with system, with provider colleagues, to help us understand what we can do that will be most useful as a sort of national team. Really keen not to create some sort of monolithic national programme with, you know, asking people for returns constantly and everybody getting nothing back. This has to be meaningful. We have to be doing it in the right spirit. So we will be sending something out shortly to help us get that baseline. So just to reassure everybody, we are absolutely not going to be saying, well, here is, you know, the tier for the people who aren't doing continuous improvement. This is genuinely about understanding where we've got assets, where we've got strengths, how we can connect people, and how we can start really sort of moving forward. So there's a couple of sort of questions, prompts that we're really curious about to hear from yourselves. Appreciate we probably won't have time to have a huge discussion about it now, but if people have got thoughts or reflections, we'd be really keen to hear from you. I think we've popped in the chat the email address, but really happy and really keen to hear from colleagues about anything I've said, if they've got any reflections on those questions or any others. And I hope that's been helpful. I'm really grateful that you've given me the time to come and talk to you on what is a really busy and exciting agenda that you've got. So I'll stop talking at everybody there.
Thanks, John. And Carlos, are you going to help us with some of the questions? or do you have a question?
Yes, we have a question from Shmuel. And the question is, what, according to you, needs to be a role of government and public health service systems in process of improving patient care?
So I think that is a great question. I just caveat it by saying I'll give an opinion, but I'm obviously not an authority on it. So I think that for me, it plays a really, really important role. So a couple of reflections on that. So the first is in terms of public health, that is absolutely where we should be starting. And I think all health services should be starting in terms of understanding what are the needs of our population and how are we meeting them, both in terms of providing services in response to illness, but how we prevent them. So I think it's absolutely crucial. One of the things we've heard a lot, excuse me, from colleagues in systems is the slight, the tension, if you like, from a governance perspective of the ICB, the sort of statutory NHS elements, and how's the system they're trying to sort of work together. So I think that local authorities, government, and other partners like voluntary community, social enterprise sector have a huge role in this in terms of providing care, because that is what we are talking about. So I think they have a really, really important role. I think that one of the reasons we want to do the sort of stock take exercise is to understand where there are more mature systems, where they've perhaps got a better way of engaging, what we can learn from that, how they're using the expertise that exists within not only, I think, local authorities, not only within the voluntary community sector, but actually the assets we've got in places and in neighbourhoods and in communities, and how we're doing things really differently, and how we're actually empowering our citizens, our patients, to be a core part of what we're doing. So I think they are both fundamentally important and profoundly important to what we're doing. I don't have an answer about how best to do it, but I think it is one of the things we're really keen to start exploring, because we, if we take the view that we as the NHS have got all the answers and that we're going to sort of solve all this ourselves, that is, I think, fundamentally the wrong starting point, because this is actually about people's health, not just seeing them as a sort of set of conditions, which I'm sure everyone on this call would sort of recognise. So hopefully that has gone some way to answering that question.
Thanks, John. And I've got a question from Angela Greatley, who is the chair of the Trust.
Hi, John. Yes, I'm Angela and I'm chair of CLCH. And first of all, just to say thank you so much for spending time with us this morning and sharing this very early on in the life of this organisation for you. I suppose my question follows on really from the one before, and it's something about, can you comment on how you intend to try and strike the balance between making sure that everyone is doing it and actually being an organisation that people can come to and look for help? It's an age-old problem, yep. It's of kind of, making sure it happens, being supportive. Have you been talking about this, and maybe you've some thoughts on that? Thank you.
Yeah, so thanks so much, Angela. I think it's a great question in terms of, I think, how we get the balance between giving the the assurance, if you like, to sort of paymaster government that things are progressing, as opposed to doing something really differently, because I think it's really important that this looks and feels different for people. So when we put out the communication, the email next week, it's going to have two things in it. One is a self-assessment for organisations, which is something people asked for. And so we're trying to respond to that, going, people thought this would be really helpful. And we've had a number of conversations about what would be helpful would be if there were facilitated conversations about a self-assessment, rather than us, as we might traditionally do, go, just fill in this spreadsheet and send it back to us and we know sort of how you're doing. And alongside that, we are trying to do, as I said, that baseline exercise. And so I think we're trying to demonstrate a sort of, there are some things we have to ask for, but we want people to be pulled toward this rather than us pushing stuff out. What we're really keen to do, I think, is that the NHS Impact sort of website becomes not a couple of documents, but a library of stories, of really useful tools, of a way of sort of connecting people, so that we do genuinely have that enthusiasm and that desire for people coming seeking out what we're doing. So I think we've had a number of conversations about this in terms of, as you say, the sort of the push and pull, but we are really clear we want people to want to do this, because if we're in a position where we're saying, look, organisation X, you've not engaged, you now have to embed an approach around continuous improvement, we know that will not work, and we know we'll have failed if we get to that point. So I don't think we've got a perfect answer or idea, given the operational pressures we're under and the constraints that we are working under and the expectations of government, quite rightly, but we are trying to make sure that we're balanced in terms of offering things that we think are helpful and supportive, and where we do need stuff back around sort of the assurance point, that we are doing that in as measured, co-produced a way as possible where people get value from it. So I think it's a really great question, Andrew. I don't think there's an easy answer, but we are really mindful of it, and we are I'm sure we'll continue to learn about how best to do that, so this doesn't feel like another thing that we are just returning stuff to the centre and we sort of get nothing back about. So hopefully that has slightly answered your question, if not entirely answered
it has, and I think it's really important that we keep testing together in a way, isn't it? Is this the way to do it? And there
Yes.
isn't a right and a wrong, but there is a way forward, and I think that's great what you said, and thank you, John.
Thanks, John. And Carlos, I think we've got another question maybe from Jen.
Yes, Jen, but before Jen, Sid, maybe do you want to come in and ask the question?
Yeah, of course. Morning, John, morning, everyone. So later in the agenda today, we're talking about the Quality Coach Development Programme. It's a programme we designed with, excuse me, I've got a cough, 23 other organisations through the Q community. It focuses on building QI coaching capability. Obviously, there's a relationship between coaching and leadership, and our programme has a strong focus on the human side of change and the psychology of change. We would be really keen to be part of that co-design of the Leading Change programme. Obviously, we can bring our experiences of the co-design itself of the coach programme, but also pull on loads of resources and expertise from across the country. Can we do that? Is that something we're able to do?
Yeah, so really great sort of suggestion. So firstly, I hope your cough gets better. It's the first thing to say. And the second thing to say is we have been talking to the Health Foundation and Q community quite extensively already, because one of the things I'm sort of really conscious of is that we have got, I think, a load of assets that you guys are clearly really sort of tapping into and using around the Q community, around IHI fellows, which might not sit in sort of traditional parts of organisations that we recognise as improvement capacity and capability. But I think there's absolutely now is the time for us to be aligning, galvanising the work we're doing. So we're already engaging with the Health Foundation in terms of the specific work that you've described, Sydney. Jodie's popped in the chat the link, and we'd be really keen to hear about what you guys are doing, how it's worked, how we can take that learning and feed that in to the design development of what we are doing nationally, because again, we do not have all the answers around this. We are really clear we don't have the answers, and I don't think there is going to be a single thing or a sort of silver bullet that is going to work. And it's about how we build up that library of, here are the resources, here's what's worked, here's how we can take the learning and apply it elsewhere. So really welcome the offer, and suggest if you sort of get in touch through the link that Jodie has popped in the chat, then we'll pick up that conversation. That really helpful offer. I'm really keen to learn a bit more about what you've described, because again, I do think there is a huge role here for some of the assets we've got in our organisations, in our places, in our communities, like the Q community, which I think have been really well developed, but I think we perhaps haven't been as good as we could be around how we utilise them and align them against some of our really significant challenges, because we've got a lot of expertise and capability in there. So really great offer. Thank you, Sydney.
Thanks. I think that brings us to Jen's question that sort of follows on. Carlos, do you want to read that out?
Yes, so Jen has a question about NHS impact and job plans, but there are a few abbreviations I don't know how to decipher. So, Jen, if you could help us.
Jen, do you want to come in?
Yeah, hi. My question was around how is NHS Impact going to work with what was HEE? So now, and I think I got it, NHSE Workforce and Education, I think, about mandating improvement work into people's SPA section of a job plan.
Yeah, so that's a really great question. So The team that are designing the Leadership for Improvement programme are the Workforce Training Education team. So they do cover what was HEE in the new NHS England structures. They're involved in it. I think it's a really, really thoughtful question about the sort of the SPA and how with medical colleagues we sort of have this embedded. I don't have an answer to that. I think if you've got any ideas or thoughts, be really keen to hear them. I know from my personal experience, one of the things that we got huge value out of were things like newly appointed consultant programs, where we had specifically aligned the work and the projects that were being done to the organisational priorities. So I think there is probably something we need to think about more broadly, but I don't have an answer about mandating it or whether we're going to do that. But if you've got sort of thoughts or reflections, I think we'd be really keen to hear how we do that. I think the work that is being done at the minute, I think the first stage of it, so we're really clear this is going to be for everybody. And I think the point we're starting at is about sort of chairs and boards, because there's a lot of evidence about training of individuals is far less effective than training of teams. And actually, when we're training teams and in terms of organisations, the role of the sort of board, the chief exec, in terms of setting the culture is critical. I think that's one of the really powerful things about today in terms of the chair, chief exec being here, spending the time doing it, dedicates how important, demonstrating how important it is to the organisation. So I don't have a specific answer about whether it will be mandated or not and how I'll do this medically, but really keen to hear thoughts. But it's absolutely on the radar, Jennifer.
So Jen, let me come in as your chief exec and previous director of improvement in many guises before. So it would seem odd for me not to pick up that baton and say to you, I'd like you to work with us to think how we do that. I don't think sometimes we should require mandates. We have the ability within us to make the changes that we want to make to improve that. But I'd probably go a bit further. I think, John, we might need to have a more national conversation about how we actually embed this as part of national training for registrants and non-registrants, so that we start to build this as a normal process. So colleagues will know that I am a trained speech and language therapist, and part of my training was actually about QI and QI methodologies back many years ago. How do you deal with a problem when you don't know the answer and you're going to have to try and work with your resident or your patient to improve their outcomes? Carlos, I think we had one more hand, but it's gone down.
Yes, but there is a message from Jody, not a question, but an invite to share improvement stories with England.improvement delivery. So I think it's for John.
Great. So I think that's more, how do we share the really good work that we've done as an organisation and specifically with our partners. But I'd also encourage partners who are on this call, if you've got evidence in your place or with your colleagues or with your residents, things that are working really well, to use that link as well, so we can get a really strong national understanding of QI and improvement methodology. Going to get one last question, and that is from Chad Hockey, who is one of our divisional medical directors. Chad. You maybe, I can't hear you. Chad? Oh, can't hear, mate. Do you want to put it in the chat? Oh,
we do have a question from Christine in the chat.
Okay. Chad, pop it in the chat. We'll do one from Christine and then one from you, and then we'll hand up.
So the Christine's question is, how is the NHS impact linking into specific conditions linked with the NICE guidelines for clinicians, for example, epilepsy?
So really great question. At the minute, we're not linking into specific conditions. In the sense of us setting out national priorities, I think that we're really keen that we are working with organisations, because every organisation is going to have a different sort of set of priorities. So we're really keen that going forward in terms of the development of NICE guidelines, which I know the development of them do use quality improvement really significantly, that we get to that point. But at the minute, we're not picking specific conditions and saying this is going to be NHS impact. Because again, I think to the point earlier about, you know, the sort of push and the pull, organisations will have their own priorities where they've got the most significant challenges around sort of access and equality. So we're not picking specific guidelines at this point that we're saying we want to focus on condition X or Y. We're really keen that organisations are empowered and enabled and have the skills and capabilities to focus on what their priorities are.
Thanks, John. And Chad, I can't see your question come yet into the chat. Carlos, can you see it?
No, not showing.
Okay. So Chad, I would really invite you to ask that question of the team via the link, and we can get a response back. I'm mindful of time. John, it's been an absolute pleasure to have you with us this morning, and I think it's really great for the organisation and colleagues on this call to see how NHS Impact is changing that landscape and really thinking about the way we have not necessarily a consistent method of improvement, but actually embedding improvement into our organisations and specifically into our partnerships within the places in which we work, because increasingly this is not going to be about organisational form, it's about how we work with partners in our local systems at place in right of the residents that we serve to improve their health and care. So John, again, thank you very much. Now, as is usual tradition, I am handing over the chairing of the conference to Angela Greatley, our chair. I do need to go and meet with colleagues to look at in one of the places in which we work, so the City of Westminster and the Royal Borough, how I, with colleagues, start to think through the use of our resources to improve discharge and discharge flow. So it's a real pleasure to be with colleagues this morning. I will probably try and pop back later on, but Angela, over to you.
Thank you so much. Can I invite colleagues on the call to thank John as well? I would say in the usual way, but it's in the new way, isn't it? Let's have some virtual clapping for John as well. Thanks all. That was a fantastic start to the day. And I think we are really pleased that the new organisation and the leadership of that new organisation recognise that we are a trust that's worth visiting, worth being involved with. And during the course of the morning, I know that we will be showing that. So fantastic start to the day. I hope we've all got through our various little niggles with websites and joining and so on, and that I can see some people, I hope everyone is able to see and hear what's going on during the rest of the morning, because we're going to take a look at improvement and quality management systems, QMS. You know, all of you know, and we're coming to the understanding that for the delivery of high quality care, we need to have a consistent and coordinated approach to managing quality throughout every level of the organisation. And I think particularly this is an area of enterprise, if you like, of work in the NHS that has been a bit characterised over the years by great pilots and ways in, but they haven't always been able to get that seed and to grow into something really powerful. But I think we've got the opportunity to do that now, so that QMS across is really important. And I'm delighted now to invite Elizabeth Hale, our Director of Communication and Improvement, and Jem Razazaglu, Quality Improvement Manager for the Trust, and they're going to take us through some of the work that's going on in that. Shall I hand over to you first, Elizabeth?
Thank you very much, Angela. I am absolutely delighted to be here, and I want to welcome everyone. We've got a really large number of people. I think we're about 170 when I last looked on the call at the moment, which is fantastic. And I know how busy everybody is, so it's you finding time, making this a priority, carving out time in your day. So thank you for that. Gem and I are going to take you through some of the highlights of our QI story, sharing where we've been and where we think we're going. And we're going to use the NHS Impact Framework that John has just taken us through as the structure to tell that story. And Gem and I are very delighted, more than delighted, very excited that the framework has been launched. It has taken, as John explained, quite a while to develop. Lots and lots of people were involved. Certainly, I know Jem was involved in its development, as was I, and I know Joe Medhurst, our previous medical director, was involved in the design of this as well. So we do feel a sense of ownership of the framework, and we really do want to make this work. So if I could just have the first slide that shows the framework. Now, this is the slide that we've been using internally in the trust, and it was the one that was launched first. Now, when John took us through, he had a lovely green slide that went from left to right. Ours goes top to bottom. It really doesn't matter. It's all the same. It's 5 pillars, and we're going to structure our talk today through that lens of this framework. So I'm going to talk about the first one, which is about building shared purpose and vision. I'll then hand over to Jem, and then I'll finish off at the end talking about how we embed a quality management system, and we really are starting to make some progress on that. So if I can take you to the next slide then, which is the first of the framework. So this is the shared purpose and vision, and the words on here are taken from the NHS Impact Framework. So we've put those up there very specifically so that you can see them, and that's the structure for the slides that we've got. But I just want to say these pictures on this slide are mine, and I have chosen so that I can really illustrate what it is that I think is particularly important about shared purpose and vision, because really that question goes to the heart of this, is what are we really here to do? And I think here at CLCH we are clear about what we're here to do, and that is to provide great care. And when you talk to staff and you talk to leaders across the trust, we are clear that great care is care that is of really high quality, but also increasingly that we're working in an integrated way, and that definition of quality includes the concept of equity, so that care that's high quality but isn't thinking about, well, are people not accessing our services, or are outcomes for some parts of our population not as good as others, can't really be high quality, can it? So those are things that we are focusing on. And it has been a particularly good week. Jem and I were talking about this earlier this morning. I had the pleasure yesterday of going to Willesden to celebrate the fact that a team there, it was a children's services team, were the winners of the London region of the Parliamentary Awards for Health Inequalities. And we had a fantastic lunch, and the leader of Brent Council came along to celebrate the win, and there were lots of staff there from the Acute Trust, from the council, and from our own services. And that was a fantastic example of really good care designed to tackle local problems, working together in an integrated way. It was called Better Health on Your Doorstep, and it was absolutely lovely. But the question for all of us is, if we all know why we're here, to provide great care, what is actually stopping us doing that? And the problem is, and we know this, is that we've got variation. And that's the problem. And when we stand back from it, we know that stress and burnout are really, really critical. And that's why I've chosen this slide here. That's just showing those batteries which are, you know, absolutely running out of energy, and people working in a way and just trying to do what's literally in front of them, but actually that's about all that they can do. And we know that this is happening because of staff shortages. So we've got vacancies, we've got high turnover, we've got sickness, and we have committed this year to make sure that addressing recruitment and retention is our overriding improvement priority, because if we can get that right, then the great care follows. And that's why I've selected this fantastic picture of Jade Ward. Now, this again was taken this week. We've had a very good week, and it was an event that was held at Jade Ward where they were planning their work and their improvement work, taking some time out from the ward to do that and to really have a think about what it is that they need to work on improvement. And they are a pilot for us for quality management systems, and we'll say a little bit more about that later. So we need to move from that stress and the variation that we've got across the trust to make sure that we've got teams that feel that they are supported, that they're really clear about their purpose, and that they can then provide the great care that we all want to, that is our overriding priority for our patients. So Jem, I'll hand over to you now.
Thank you, Elizabeth. And thank you everyone for coming today. It's just a privilege to see so many of you giving up your time to come and listen to us and to learn a little bit about what we've been doing here and where we're going. So if we can have the next slide, I'm just going to talk a little bit about building improvement capability. So absolutely, one of the key things we need to think about is how we support our teams to tackle those challenges and building their skills and know-how and tackling problems, learning how to go about making improvements, through trial and error, testing, evaluating and iterating their approach to ensure we work out how to make things better and how to consistently deliver great care is a really key part of this approach. And we've been training people for many years in CLCH, and we've currently got three kind of key tenets of our training offer. So I'm just going to mention them briefly. So the first one is QI Fundamentals, which is basic awareness training, just to introduce the concept of what is quality improvement, what's it all about, how does it work, and that can be done electronically. We do it in person. We have it on our learning management system, and I think we've covered about 2,000 staff. I think was the latest count. So just about 45% of our active workforce have now gone through that training. The next level up after that is to go into QI practitioner, and that's really the how-to guidance, really. So if you want to use improvement skills, if you want to learn how to actually deliver improvements, this is the training that we give to our staff to show them how and introduce them to the tools and the techniques and give them some support and coaching in that process. So we run a variety of different offers. We do it virtually or in person. You can do it either in 3 full days or for those that are struggling to make that time due to clinical commitments, we offer it in 8 short bite-sized sessions. And I think currently the latest count, we're just over 200 active staff who have completed that training. So really starting to grow the amount of people in the organisation who've got that know-how and the ability to just drive improvement confidently themselves. And the last one, our gold standard training, is the Quality Coach program that's been mentioned a couple of times today, and really just a fantastic piece of work. And I'm not going to steal Sid and Hannah's thunder by talking too much about this, because you will hear a little bit more about that a bit later today. But just to say, this is really where we take people who are have done some quality improvement, have had a go at learning those tools and techniques and had a go at actually trying to implement some improvements, but now really seeking to be able to support their colleagues who are maybe on the learning journey themselves, maybe a bit earlier in their experience of how to actually overcome that challenge between putting the theory into practice. And that's what the coach program is for. And we've run, I think, 3 cohorts now, and we're currently got 35 trained coaches with many plans to build more in the future. But I said I'm not going to say too much more about what that is, so I don't want to steal Sid's thunder. But if we could just go to the next slide, it would be amiss of me not to shout out the fact that we were nominated and indeed shortlisted for the HSJ Partnerships Awards, and I think that was just recognition of the really amazing work that was done, not just by CLCH but by all the different organisations that were involved in coming together, indeed through COVID, in a really challenging but amazingly productive co-production to develop something which is what we see as the future of how we're going to enable this cultural shift, what it is that will actually enable us to make improvement an embedded way of working, because you can't really rely on just a very small team to ensure that happens. So I'll say no more about that, and if I just move on to the next slide, please. So I wanted to talk a little bit about the next pillar, which is around developing leadership behaviours, and that's about really talking about what is it we need to do as leaders in an organisation, what would we need to do differently in order to support this different way of working, and that's really a key focus on instilling those behaviours that enable and support improvement both within and across organisations. So just a little potted history. We've done some work on this over the past. We've had our board go through the NHS Improvement Board Development Programme back in 2018, and since then we've also had some more support and coaching to develop a set of leadership principles that we believe are going to underpin that culture that we're seeking to create. And obviously, as John shared earlier, there's the new Leadership for Improvement programme coming, so we'll be doing more work to try and align ourselves to ensure we're continuing to support that. One thing that we have been doing really well, I think recently, is starting to introduce SPC charts, that's statistical process control charts, as a way of supporting better decision making when using data. And I think that's now being incorporated into all aspects of both board and divisional reporting and performance and quality. So that's been a really key shift for us in learning how to use data in a more intelligent way to make really good decisions about how to react when things appear to be getting better or appear to be getting worse. And finally, just to say, we've agreed with our Modelling the Way committee, which kind of oversees leadership development, workforce development, that will be embedding improvement leadership training into all of our leadership training and development programs across from top to bottom in the organisation in the future. And Sid and the team who are leading on the QI training are working closely with the Academy and OD colleagues to do that. And I think if we go on to the next slide, the last one I just wanted to talk a little bit about is how we support investing in culture and people. And that's really what are the systems, what are the mechanisms we're putting in place to actually enable people to make improvements and supporting and encouraging them to do so. So the first one I wanted to shout out is our shared governance programme. So it's been around for about 6 or 7 years now and growing over time, but this is absolutely pivotal part of how we support and enable improvement in the organisation, is giving a voice to our staff to actually allow them to identify things that they think need to be improved. And it's not necessarily all done as a top-down approach. This is absolutely giving a formal voice to our staff to enable them to identify ways that we could improve and to be able to give protected time and support to test out ideas. And we've seen some fantastic examples coming through that. And I could list hundreds, I'm sure, but I probably don't have time to go through them all today. But it's been a really, really fabulous programme and continues to be a key part of how we support improvement in the organisation. Another thing we've been doing over the last few years is using improvement collaboratives, where we're taking a kind of a key core issue that we believe affects multiple teams, multiple parts of the organisation, and creating a space and a kind of a facilitated environment for teams to come together and share their learning and thinking about how are we going to tackle these problems. So we've run 3 improvement collaboratives now in the trust. We've had one most recently on health inequalities, which finished yesterday and was a fantastic event, really highlighting the value of bringing people together to cross-pollinate their thinking, and so many examples of just great engagement where people have learned how to use their data better to understand where they've got inequality gaps, how to target their interventions more appropriately, and not just that, but also the importance of understanding what the different voices in our communities will bring to our thinking, and how important it is to reach out and engage with them, and how to do that really well. So brilliant examples coming through from the collaborative yesterday. And on the same note of supporting our staff, we've also had 2 collaboratives supporting joy in work. So those not familiar, it's really about how do we focus on well-being and bring joy back into the workplace, because we know that happy staff deliver the best care and unhappy staff don't, and that's well evident. So we've really put a lot of effort into supporting our teams and our staff to think, how can they focus on themselves and give them the ability to just have a bit of space and time to do that. And we've had 2 fantastic cohorts of the Joy in Work Collaborative, and we'll be, I no doubt, doing more in the future, as this has been a very popular topic. Improvement priorities, I think this is a really important aspect. So I think that sometimes we have so many things to do that we're never quite sure which one to do first, but having absolute clarity on what are the priorities that we need to focus on when we're trying to improve is a key to enabling people to make that time and space. for improvement. So we've talked today about how we're going to be focusing on staff and well-being, and that is absolutely going to be key for us, as well as the national priority to continue to support healthcare inequalities. So another kind of mechanism we've been using, just wanted to, Charlotte, talk a little bit about how we're helping teams, and another example from Jade Ward, where we've been piloting our quality management system, is helping them introduce improvement huddles to say, well, actually, if you don't create space in the week to improve, then there really isn't time to actually do that thinking. And that's really a key part of what we're doing now, is thinking, how do we ensure that improvement conversation is part of how we operate? So building space and a place to say, well, actually, what are the things, what are our priorities locally to improve, and making sure those people have a bit of space, have the right tools and the right training and support to enable them to have the right conversations about, well, what are the issues, what are the barriers, how can we overcome them, what could we test, and evaluating whether or not those are working is an absolute key component of how we see this working going forward. So I think that's probably everything I'm going to talk about now. I've got so many more things I would love to talk to you about today, but I just don't have time. But there is obviously going to be the panel later. So if you do have questions about anything I've talked about, please do put them in the chat and we'll pick them up later. But for now, I'm going to hand back to Elizabeth. Thanks very much.
Great, thank you very much, Jen. So this is the last slide, but before I get into this, if I can just mention, just building on a couple of things that Jen said there. First of all, the picture of the staff in the huddle was, again, Jade Ward, and them carving out time to do that improvement work. So it has been lovely to be able to have those pictures and to bring them to you. The other is, for me, is the collaboratives. I took part with the Joy and Work collaborative that we've had for Marylebone Road, and learnt a huge amount from it. It has been really, really important, and we continue our work at Marylebone Road on that. But the trick for us as a community trust that is really dispersed and people aren't always coming together is to have those opportunities to share the learning across teams that are geographically very widely spread. So it has been great. Anyway, to the final slide. So we've heard about the QI skills and the strength of what we've been doing, and we knew that the NHS Impact Framework was coming. And so Gem and I in the background have made a proposal which has been accepted through our ELT, our executive leadership team, that we will take this approach and formalise it across the trust. We've had a really good number of volunteers to join a steering group that will oversee that work. And the first meeting, that inaugural meeting of the steering group, will take place later this month. So just that you're aware, so that's where we are here within the trust. So really for me, it's to say, well, what is that quality management system, that NHS Impact Framework going to give us that we didn't have already with the QI work that was happening in the trust? And I think for me, what it will do, it will enable us to have one kind of simplified, overarching way of looking at all our plans and embedding improvement into the DNA of our trust, so that it's not just, as John described, something that's kind of nice to have. And I think his example was handing out iPads to patients that are sitting in a waiting room, but rather it's just, this is the way that we deal with the big challenges. This is the way we think about how we improve our organisation throughout all of our teams. And when I say all of our teams, that does mean everybody. So it includes clinical support and corporate services. So the approach applies just as much to HR and IT and other corporate services as it does to our clinical teams providing direct care to patients. So we will then have everybody focused on improvement and being able to identify, everyone being able to identify what it is that needs to be improved, and then supported to find solutions, so that that is systematically built into the way that we work. And everybody being really clear about what's that gap, where are we now, and where do we want to be, and what are the steps to get us to that solution? What do we need to test out and try and make sure that we can close that gap? Now, I will leave you on something which sounds, it could be a bit of a downer, couldn't it? Because this isn't a quick fix. And I think we all need to be really, really clear about that. But I think what I hope that you've taken from what Jem and I have described so far is that we have made a really good start. We have a lot of the building blocks in place, and we will continue to progress with those. And we do have fantastic teams out there doing fantastic work, and some of them are already leading the way in this new approach. And obviously we have singled out Jade Ward this morning as our pilot. So thank you very much, everybody. I hope we haven't talked too much and that we do have time for questions.
Thank you, Elizabeth and Jem. Adopting QMS will ensure that we do have a process with the same information, skills and controls and consistency. So it's great work. Can we thank Jem and Elizabeth? But also, are there a couple of questions that we've been picking up from the chat, or indeed any hands up?
Hello, Carlos and I are monitoring these chats. There have been some that the team have been responding to as we've been going through, and there are a couple on SPC, but I think that it might be good to save those for the expert panel at the end so that Jem can respond to those.
You're happy to pick those up at the end? Yeah. So there are no live questions sitting waiting for us at the moment, and we have got something there that we're going to look at later. Just as I move to introduce the next speaker, I do want to emphasise to everyone something that was in the contribution from Elizabeth and Jem, which is that the board itself is incredibly committed to both leading and supporting and being alongside all of you. And I saw earlier that my colleague, Carol Cole, who's the Vice Chair of the Trust, is on the conference today. And I have to commend you to know that Carol is an absolute leader in this area of quality improvement, not least in the use of SPC. I think she helped us, cajoled us, and made us go in that direction. So it's been a great exercise for board level people as well. And thank you for that. But we're now going to hear from one of our clinical psychologists, Alicia Nambarala. Alicia works in the clinical psychology department within the Child Development Service, and she'll be talking to you about her QI project, which looked at a novel parent group designed to reduce the number of individual work referrals. So I'm really looking forward to hearing this as well. I'm going to hand over to Alicia, and I see her slides are up there. Thank you.
Hi, good morning, everyone. My name is Alicia. Thank you for the kind introductions. And I did the QI practitioner project last year, and it'd be really great to share with you what I got up to, and now in reflection, because it's been about a year since I finished, what we've been up to since the QI project. So next slide, please. So I've been working as an assistant clinical psychologist at CLCH for just about 18 months. And as I was kindly introduced, I work within a child development service, and specifically, I work on a school-age social communication differences pathway, where we do assessments for autism primarily. And the main role of psychology within these assessments is doing an ADOS, which is a play-based assessment to help diagnose autism. So the novel parent group that my department had put together was called Embrace, and it stands for Emotional Regulation, Milestones, Behaviour, Relationships, Achievement, Communication and Endeavours. And this was actually developed from previous sessions we had with supporting early years practitioners in local nurseries around RKBC and also Westminster to support the staff understanding children with big feelings. So usually these children are already identified to us through our child development service with additional needs or on the neurodisabilities pathway. And the main focus was helping create a supportive space for parents to learn about emotional regulation for ourselves, and to help them connect other families who are local in the area, who will definitely have quite a huge involvement with the child development service in the first place. And we do focus on typical development, thinking about languages and emotions, but also exploring behaviour as communication, and actually addressing different parenting styles. So we focus on developing different strategies that parents can use to manage their common parenting challenges. So the aim of this group was to increase the knowledge of child development and introduce people to other families, and also to provide resources of understanding and connecting other children. And we run this group of 7 sessions. Next slide, please. So we identified the problem is that we found that with families who have children with additional needs, particularly children who haven't yet to be diagnosed with autism or any other learning disabilities, it can be quite overwhelming, the amount of care and support required to take care of the child, whether they have additional needs or not, but just those big feelings, sometimes those terrible twos, or the tricky threes, as we've heard. And oftentimes these parents are often in fight or flight mode and find themselves referring themselves either to CAMS or referring themselves to us multiple times a year and still not feeling quite equipped. And we actually found that being a dysregulated parent makes it really hard to regulate a dysregulated child. And this also has an impact on us because we have limited time and resources. Though we'd love to definitely extend our hand to all these families, we have limited time and resources to actually accept several individual work referrals. So for piloting Embrace, we actually gathered 6 to 8 families that we thought would be interested in joining, and we asked different disciplines from physiotherapy to speech and language therapy to special health visitors who they think that would have been good to join our group, and we made sure that it was reflective of the communities that we serve, making sure that they were diverse, mixed culturally, ethnically, and also in terms of the makeup as well. So we actually had a really good group of people from different walks of life, which was really reflective of the people that we serve in the community. And we were interested in having families that do access primarily the child development services and went through the pathways that we have on offer. The group was run online, and we had difficulties with organising interpreters as it is a group. So we did want to make sure that people's first language was English, and we do recognise that could have been a difficulty because it means that we've shut out some groups if we're not able to access an interpreter. And we also wanted to think about the relationships that these families may consider and have the expectations of from healthcare professionals and how this might impact their health-seeking behaviours. So some families, they may see us as the rescuer, or they might be quite independent. So that will probably also impact how they engage with our pilot. And we also want to think about how this could help us reflect on the existing groups we already have and how we understand the information that we're collecting. So I created the fishbone diagram, which with my team to think about the focus of the problem rather than its history. So I thought about how we can think about how engagement really impacts from different aspects. So thinking about patient factors. So this was a pilot study. So we really wanted the patients to know that, patients and their families to know that they are stakeholders when we are creating this novel group, and we'd really enjoy their impact in how you can help us develop the group further, and also thinking about their availability. There's also practical things, so communication factors. So this group was actually multidisciplinary. So thinking about how the other parts of the MDT will think about their roles in what they do for us. Also just availability for session planning. It could be really hard, just like this morning, to get everyone on board at the same time. So that was really important. Also other practical things, thinking about equipment, how we bring the resources together, and also how we apply for funding. So we actually created some parent packs. So we had to think about how we can apply for funding, and also just things like virtual fatigue, and not being able to gauge feelings as it was an online session. So the aims of our project were primarily to reduce these one-to-one individual work referrals that we were receiving through using this group. And our objectives were mainly to think about increasing parental confidence and skills and knowledge of their children's emotional regulation, and also assessing the input that our team was putting in. So are we actually putting in more effort when we're doing this group, or are we picking up more or picking up less work than we thought we would, and also how we can increase the awareness of this group in our service. So I'd also thought about developing a driver diagram. So we include some primary drivers, which are main ones of thinking about the peer support, thinking about the feedback we're receiving, and also thinking about the time spent. And we had secondary drivers and change ideas that helped us think about how to run this pilot group. So my main measures were thinking about parental confidence, which we actually used a weekly online feedback form after each session, using Microsoft Forms, which is a great application. And one of our balancing measures was definitely thinking about our input in preparation for these groups. And what we did notice over the weeks through getting the feedback from these weekly forms was that the parental confidence did actually increase over time. So we found that parents did feel quite deflated at first with the information because it could be quite overwhelming. And so we thought about how we can restructure that. We did want to emphasize having a co-production element and not making it very, I guess, more jargon heavy, and thinking about how we could change things. We also did notice that where there was a break, there was time for parents to reflect and see the information they're receiving, and that's where the confidence actually started to increase once we had a break from the sessions in the half term. So I also, sorry, my voice is going. When we thought about how to support families with creating some aims and some goals for when they first joined the pilot group, we thought about actually including SMART, and that's something I learned in the QI practitioner project, of how we can actually support ourselves in creating SMART aims. Sometimes, like I said, there's this whole emphasis that once we have a group, parents should know every single thing, and I think that's what some parents sometimes do think that they'll get from a group, but we actually wanted to help them with supporting and creating realistic and timely goals, so that they know that this is probably not going to solve everything in the moment, but definitely help along the way. And this actually helped foster a more therapeutic approach to how they understand their children's needs, and that was reflected in the previous slide, where the confidence did increase, where there was the reassurance and check-in points during the half-term break to reflect on how much they've learned and how much there might be still a way to go, but they've learned already a lot. So just some reflections. Overall, we did see parental confidence increase, which was our main focus. And they learned so much more in accordance to their needs, and we've actually now continued about four different cohorts of Embrace since we first started. We've also thinking about how we can review for feedback in general. So we've actually had meetings of how we can review feedback for all groups and actually review feedbacks for our assessment pathway, which is different to groups. We've also thought about logistical changes as well. So we've been balancing how we can actually combine face-to-face versus virtual. So for our Embrace sessions, we have a coffee morning at a local church right next to Royal Oak Station, where we gather together, and it's really nice because we get to know each other in person, and it actually makes a huge difference. People put their cameras on more when they've seen each other in person, and it's nice to bond over biscuits and tea and meet people's children in real life as well, which is great. And we've also thought about how we should consistently be taking feedback at all different points so that we can learn and grow further. So our next steps is that now we've considered how we can involve from the referral intake meeting stage. So I'm part of the referral intake meeting where we receive referrals from local schools and GPs, how we can actually, when we do see there are some behavioural difficulties or communication difficulties, actually how we can offer something. Currently, our autism waiting list is about a year, which is not great, and we're trying to definitely decrease this. So up to 10 months or so, but that can vary. So actually we offer some support in the meantime by attending Embrace, meeting local families. Through meeting local families, you can find out about local offers and initiatives, half-term groups, after-school groups. So it's a really great way to offer and contain families during this period of time. Also trying to make our service Embrace friendly. So we do try to emphasize the actual leadership competency of clinical psychology and how we can supervise neurodisabilities meetings, encourage people to be Embrace friendly in their practice, just to help support families through different pathways and through different disciplines. We've also applied this to patient stories. So we had a pilot. We had a focus group with the families we first met with in our pilot study to think about how they found the experience, and we developed a patient story, which I fed back to the wider team. And also thinking about the legacy of Embrace. We want to try and push it forward. We've gone in a year now, which is really great, and we're looking forward to what's going to come next. And this is just some feedback that we received in the focus group. So it was really encouraging to see that we did make a difference for people, and we do see that these families are thriving, and that's the really good part about it. So yes, I think that comes to the end of my slides.
Thank you. Thank you, Alicia. That was a really fascinating insight into the Child Development Service. And I think in the slide before that one, you really picked up an important point, which is the sharing of the kind of clinical disciplines as well, the interdisciplinary nature of learning from each other, because you've brought all of those things to your QI work, and I think that's just really fascinating. I think Hannah and Carlos, have we got time maybe for just 2 quick questions? Because I think there have been hands going up.
No questions in the chat. Lots of congratulations on the great project done. But if you do have a question, please just type it in the chat, and then Alicia could pick it up from there.
Okay. If there's, I think there's a question about how many people in your team, and Alicia, that's one I can see in there.
Yeah. So in my team, we currently have about 5 people, but these changes are quite recent, but we've had to have some funding for more roles, which is great. So we will be recruiting more people, and that's just really great, because then we can expand our offer, and also think about ways that we can still pick up individual work for families who might need the interpreter or might need one-to-one, but also continue offering our groups.
That's great. And just our thanks again. And I think the questions that have come in the chat, people will pick them up, and then they can make contact with you. You can see what people have been asking. But thank you very much, Alicia, for sharing that insight. And next up, we're moving to another clinical psychologist, Dr. Yakovina Kutufa from Kensington, Chelsea. It's the Tier 3 Specialist Weight Management Service, and this is piloting the use of the AirMid app. So welcome, and let's take your session, please.
Hello, thank you, Angela, for the introduction. Hi, everyone. My name is Yakovina, or Jackie for for ease. I'm a clinical psychologist in the Tier 3 Weight Management Service. We cover the Kensington and Chelsea borough. So I'll talk you hopefully briefly through, I'm conscious of the time as well, through through our QI project. A little bit about our service. So we're a multidisciplinary team. There's myself. We've got a couple of dietitians, a physiotherapist, and a consultant endocrinologist. We see people for up to 2 years. So as soon as people are referred into our service, they can stay with us for up to 2 years, which is quite a long time for people to kind of try and make some changes. Our main approach is through lifestyle and behavioral changes. So for now, we don't prescribe any medication. If people are interested in bariatric surgery, we refer them onto the Tier 4 services. So our main approach is lifestyle behavioral change. And the way that our pathway looks like at the moment in terms of approach, we have recently started a new 6-week intro group for most patients, followed by an individual review, and then people can see each of us on a one-to-one basis as needed. That also includes, well, as I said, one-to-one sessions, a walking group, exercise classes with our physio, and an emotional eating group. So it's quite a lot of multidisciplinary input for our patients. However, as I think most teams will have experienced, especially after COVID, we have seen an increased caseload, and this is where kind of our problem statement comes in. So especially after COVID, we've had a lot of new patients. I would say our caseload has increased from about 300 prior to COVID to maybe 450, and the team hasn't changed, so we're the same amount of people just working with more patients. But we've also seen that people take up much more virtual care, so online appointments, whether through video or telephone, plus a lot of online groups. Which obviously highlighted for us the need that we need to increase a little bit our contact time with our patients, especially with weight management. We know that increased contact with professionals leads to better results. But we also needed to do that in a way that was cost efficient and time efficient as well. So in terms of the fish diagram, just to think a little bit about the various problems that came up. First of all, there was something about facilities. So we have a limited space for face-to-face consultations as a community team. And of course, because we cover the whole borough of Kensington and Chelsea, the convenience of location was not there for a lot of our patients. The clinic hours as well. So we have a lot of people who work during office hours, so we weren't able to see them, or they struggled with engagement because of that. As I mentioned before, we're the same amount of people working with many more patients, so increased caseload. And also, particularly with tier 3 weight management and generally weight management, there are a lot of client comorbidities. So things like mobility issues, limited time for us to do home visits. And obviously that culminated to long waiting times for follow-up appointments, leading very often to patient disengagement. We got to a point at some point that the follow-up sessions with dietitians were every 2 months. So this was really not working for a lot of our clients, meaning that they were disengaging from the service and we weren't really seeing many results. Similarly, for psychology, there was at some point a waiting time of, or a follow-up time of a month. So people were having one psychology session once a month, which is not ideal. When we say that ideally it's weekly, the way that it works for us now, it's mainly fortnightly. So what we thought, we know that there are a lot of mobile apps at the moment that support weight management across a wide spectrum with more or less support from professionals. So what we've tried to do, and our team lead Lucy Pero, she's been fighting for this for a long time, but trying to find an app that would help us with increasing that contact, which obviously became especially needed following COVID. So we introduced the Airmid app, which is an app that it's an adjunct to System 1. So we didn't have to pay anything extra for it. And it's an app that is already used by a lot of GP practices and other services as well, mainly for appointment scheduling. But the way that we tried to use it was to send weekly resources from all of us, from all disciplines, psychology, physio, dietitians, to increase contact and engagement. That was one of the purposes. The second thing was to try and facilitate collection of outcome measures. Again, following the lockdowns, we really struggled with collecting outcome measures questionnaires, because previously it was very easy to give people paper copies, give them 5 minutes to do it in the session, and we had them. And then the third aim for using the app, which we haven't done yet, but it's in the plans, to facilitate direct communication between clinicians and patients. Now, at the moment, we use email a lot to communicate with patients, but having everything in one place and obviously giving patients the option to respond to some of the resources that we send them, give us direct feedback would be really useful. Although we haven't done that yet for reasons that I'll come on to in a moment. So the aims of our project, of the QI project, first of all, we wanted to understand the issues and the benefits of using this mobile app, using Airmid to support weight management and support communication between patients and staff. And in terms of setting a kind of a SMART goal, we wanted to increase use of the app within 6 months of app launch. How we defined use of patients signing up to the app, reading the weekly resources, and also clinicians using the app to send individualized messages to patients. And in terms of more the process outcomes, we tried to understand the barriers and the benefits of using this pilot app. Our primary drivers was to help patients increase their motivation and engagement with the SWIMS program. To support patients to lose weight more efficiently, and helping staff as well to stay connected and monitoring in an easier way the progress of patients. Secondary drivers, we wanted to help patients to learn how to use the app efficiently and how to learn how to make the most of it. provide relevant information, and help staff as well use the app efficiently. So what we try to do, first, send weekly resources to SWIMS patients. So every Friday, one of the members of our team will send a kind of short resource, just as a bit of a reminder, a bit of contact with the patients. It might be something like a recipe, it might be a resource on emotional eating, it might be information on the role of carbohydrates, a lot of different things that people will talk about anyway in their one-to-one sessions, but just as additional reminders. We also ask patients to complete their initial and follow-up questionnaire, so outcome measures on the app. It said it's not been implemented yet there, but it has. We did that a little bit later. I have to say the uptake hasn't been great at the moment, and I'll talk about this in a second. And also we, as I said, we ask clinicians to send messages to the patients via the app in terms of arranging appointments and that sort of thing. In terms of measures, so how did we measure the kind of effectiveness of our intervention? The outcome measure was weight reduction. This is not something that we've been able to look at yet because the numbers are not very high in terms of patient participation. But in terms of process measures, we wanted to look at how easy it was to use the application, how easy it was to access the application, how frequently patients were using it, and also the friends and family test, so how much they would suggest to friends and family. What we found, I'll start with the planning, with the kind of right side of the slide. What we were hoping to find was that service contact will increase. We wanted to see long-term significant weight reductions in comparison to a group of patients who didn't have the app. And we also wanted participants or patients to use the app for resources in between sessions. How we tried to measure that, we created a short feedback form for people to complete electronically, which we send many times via the application itself, via email, via text messages. One of the difficulties that we found, as I said before, we have a very low completion rate so far. So out of the 52 patients that had the app at the time, only 11 completed the feedback form. And again, this is something that we're trying to consider in terms of how we can increase both the uptake of the app, but also the engagement with the feedback form. And also, one of the other difficulties was that in feedback that we got in one-to-one sessions, patients weren't fully aware of the app function. So again, maybe there's a question of how do we set the app up for patients. In terms of results, what we found was that most patients use the app at least once a week, so obviously more frequently than clinic sessions. So in terms of increasing service contact, it seems like that was working a little bit. Most patients also use the app to read resources, which again is what we expected. The second most popular functionality of the app was to complete the questionnaires and also checking future appointments with us. It would be interesting to see as a future project how much that affected our DNA rates, particularly for the group of people who have the app. 63%, so 7 out of the 11 participants were likely or very likely to recommend to friends and family. Most participants, again, about 72%, 8 out of 11 people found it very easy or easy to use. And as I said, we weren't able to compare weight data at this stage. So what we're planning to do, what we tried to do was thinking about increasing again the functionality of the apps. As I said, maybe setting it up with our patients on our one-to-one sessions in a way that helps them to fully understand what the functionalities are, how they can use it. Also, maybe considering adopting a different app to increase based on patient feedback, which I'll come on to in a moment, and maybe adapt a little bit the functionalities and uses. So these were some suggestions kind of from qualitative feedback for improvements from patients. So first of all, and this is something that we were expecting as well, that the AirMed app is great because it's very simple to use. It's very easy to book appointments. It's very easy to look for your appointments, but it's not very specific for weight management. So a lot of people suggested that obviously we incorporate elements that were specific to weight management, such as tracking weight, accessing their medical records, accessing messages. Obviously, having something like a link to a food diary or a meal diary would have been great. At the moment, we ask people to do that either on paper or on email, but it would be great, again, if we could bring that all in one place. And the other suggestion was the two-way communication. So as I mentioned before, AirMed allows for communication between patient and clinicians. So people found it helpful to have that communication directly from their clinicians, but they would have preferred if it was a two-way thing. Now, our concerns with that was that we need obviously a safeguarding system in place, because the app messages come straight through to System 1, so they're obviously not checked regularly or consistently. So we need to have a think a little bit about how do we increase the two-way communication in a safe way. I can see there's a question about the slides moving on. I hope everybody can see the correct slide. I've been moving them with on my screen. Okay, perfect.
I've got 48, Jacobina.
Okay, perfect. So you can see the suggestions for improvements slide. Yeah. Okay, fantastic. So in terms of conclusions and next steps, it's quite promising initial results. I know it's a very small sample at the moment, but from what we've seen so far, it looks like it does increase engagement and helps us with increasing collection of outcome data. It's very positive that the majority of people found the app easy to use and would recommend. And in terms of next steps, so these are just some thoughts that we've had in our service, but I guess more generally as well. It would be really useful, obviously, to see how the use of the app affects outcome data, so affects weight. It's our main outcome measure, but also generally other outcome measures that we use, like quality of life and so on. But we do need more data in order to be able to make those comparisons. I mentioned about the two-way communication, so having it as a platform where we can communicate directly with our patients without necessarily having to have the full 1-to-1 hour session. I mentioned about adding more functionality, so weight tracking, meal logging, and we also have another QI project in process in terms of how effective the app has been in helping us with collecting outcome measures. And just another thought as well in terms of more integrated care, because AirMed is an app that is used by many services, by GP surgeries, and our trust already has access to it at no additional cost. It might be something to consider in terms of promoting integrated care. So if people are seen in various different services, they can have their care or all their appointments, all their resources in one place. So again, it's something that we can consider in the future. I think that was it for me. I don't know if there's any questions or any thoughts.
Right, first of all, thank you very much. I think seeing how the use of digital and virtual technologies is supporting patients is really important in this quality improvement journey that we're on, but also the way that you're suggesting we might be able to use this particular technology more widely in the trust. So those are all really interesting challenges you've put out for people. Is there one question or two quick questions from the chat? I'm just wondering, Hannah.
Yeah, hello. There's a question from Donna, which says, how did you get the support from information governance for the app?
Yeah, good question. So the app, it was already approved, so it's part of our trust anyway. So we didn't have to do a lot of extra work with information governance. But I can check, because this is something that our team lead, Lucy, took on. So I can check and give you a bit more detail. But as far as I know, it's already part of System 1. It's already been approved, so we didn't have to do a lot of additional work with information governance.
It's good. Is there a final question, or are the others in the chat and can be looked at afterwards? Hannah, what do you think?
There is one from Jem. Jem, I don't know if you wanted to come in on your kind of comment now.
Oh yeah, if that got just about time for one quick comment, and it was just to say, well done. You know, brilliant project, brilliant application of using quality improvement tools to help you kind of work through a problem and try an idea out and develop your thinking and reflecting. Anyone in my team and will know that I'm a massive advocate of using technology and apps, and I'm always trying to find new ways to try and streamline and make things more accessible. I think all our learning recently about inequity is one of the things that you just have to be slightly wary of when you're introducing new tech. You know, there are some amazing features that you can make available to a really large portion of your patients, but there is always going to be a group that will struggle to engage for a huge variety of reasons. And I think that's just one of those things that, you know, sometimes doing great improvements can create unintentional consequences. So something really just to say, have a think about that one maybe for the future, just to say, how do we make sure we're not accidentally causing inequity by introducing what, you know, is brilliant clearly for a whole load of other patients. So that was it for me, just to say well done otherwise.
Thank you. Thanks, Jim, for your comment. I think it's a really, really important point. And we do keep that in mind. The app is never meant to replace the actual clinical care that people get on a face-to-face basis or even telephone. So we just try to add as many resources as we can, but it's never going to replace face-to-face clinical care, at least at this point, because we're very aware that we have a lot of people who don't have access to technology. But thank you for your comment. It's very important.
Jacobina, thank you. And thank you for pulling together those really interesting strands about how the future use of the technologies might be adapted and how it might be still possible for people who can't use them or don't wish to, you know, how that might change over time. So thank you, Jacobina. That was a really interesting contribution. What we're going to do now is we're going to take our 10-minute break. Now, because the old tech was a bit bothersome first thing this morning, and thank you to all of you who made it work, I think we'll go, my computer says it's 11 minutes past 11, so let's say we'll try and start again at 20 past 11. So I'll see you all back on screens then. Thanks. So, colleagues, and Jem, thanks for putting the note in there. I forgot to put it in the chat and just announcing it for people who join. They'll wonder what's happened to us. So that was really helpful. Thank you. So as people are rejoining for 11:20, and we'll make sure that we do finish on time, by the way, because I know people have carved out time from busy diaries. So we'll get there by 12:30. We've had a really packed morning and it's been inspiring and thought-provoking. So let's move on now as well to further more inspiration, which is, as you know, we've invested in a central QI resource, and it's enabled us to have a significant progress in building trust-wide improvement capacity, and is continuing to develop that deeper understanding of quality improvement methodologies. And this is something that came out of Elizabeth and Jem's conversation with us earlier. And also the work that we've put in over the past 3 years has built that foundation for a robust support structure. And we've got QI specialist coaches and practitioners with the expertise in QI tools and methodologies. And so the next section of our work together this morning is going to be to look at how investing in the resource is starting to pay off. So I'm absolutely delighted to welcome Sid Beach, Quality Improvement Training Lead, and Hannah Pearson, Quality Improvement Facilitator, whom you've both seen already this morning, contributing, dealing with questions and so on, who are going to take you through the Quality Coach programme. Over to you two.
Thank you, Angela. Good morning, everyone. So Hannah and I are here to talk you through the Quality Coach Development Programme, which is an exciting and innovative programme that enables organisations and systems to build QI coaching capability at no additional cost. This programme was created through a Q Exchange project that was led by CLCH, but actually was a co-design of many numerous people, which we'll make mention of later. The end result of that Q Exchange project is that we've co-designed a high quality product. It's an off-the-shelf product that anyone can pick up, any provider, to deliver within their local context. So be that an organisation, a system, wherever they want to. Skip that as we've already done introductions. So what Hannah and I will cover in this session is that we will firstly just set the scene. So why are we talking about this Quality Coach programme? Why did we decide to embark on designing this and go through the effort of co-designing it? I'll then touch on the co-design process itself. So that has been a labour of love, a lot of positives, a lot of challenges. So we'll reflect on that and share our expertise and our wisdom, and hopefully you'll be able to use that in your own local context. And then Hannah will talk you through what the product itself looks like, so the Quality Coach Development Programme, and how you can go forward with this. And for our staff who are joining from CLCH, how you can become a quality coach yourself. So when we've been reflecting recently as a QI team, we've been thinking about how organisations provide QI support. We know that every healthcare provider wants to help their colleagues to improve. They strive to improve care that they provide. And we know that QI is a well-established, evidence-based way of improving. The challenge we have is that we want everyone in the organisation that we work in to improve every single day. That is not a simple task, but that is the kind of end goal for all of us. And we were thinking about how should we get there. And I think historically, we've been more leaning towards what we call a dependency approach to building QI capability and providing QI support, which is shown on the left-hand side of the screen. And in this, what we mean by that is that the QI team are often responsible for the QI work itself and are often very hands-on in the application of QI methods. So I kind of like to think of this reflecting on my own experience of me rolling my sleeves up, going onto an admissions unit and writing a rapid transfer protocol and pro forma for people to use, myself not being a nurse. So, you know, that is a very kind of hands-on dependent approach where I'm doing a lot of the legwork. In our ambition for everyone to do improvement every day, that is not very sustainable, because actually we know that everybody is now more and more interested in QI, and we can't keep recruiting larger and larger quality improvement teams. And so instead we asked ourselves, what can we do differently? And we thought about building more independence across the organisation and across the system. And so instead, we're now a QI team that's still responsible for building QI capability and enablers of improvement, but we often support people through coaching instead. And we're starting to think about how we can spread the QI bug that we always talk about to get others who are passionate about improvement upskilled so that they can support their colleagues as a friendly, familiar face who has training and expertise in the human side of change. Claire, we're on slide 56, and I'm just moving on to slide 57 for those who are struggling with the slides. So obviously, we know that there are positives and negatives to any approach that we can use. And the positives of the dependent approach is that we're often using improvement specialist expertise, and that can lead to quicker and more sustainable outcomes when done well. And often it can be linked directly to organizational priorities, as you are often deployed to an area where that work is needed to be done. However, it can send the message that improvement is a specialist skill for the elite, or that it's not available to everyone. And it limits people's opportunity to learn about QI and develop in their QI skill set themselves. And as I've already mentioned, because of the growing demand, it may require a larger team to meet that increased demand. Conversely, the independence model, it has a lot of positives and negatives as well. For us, the key thing was that it sends that clear message that improvement is everybody's job, and it helps to build a culture of continuous improvement. And hopefully it doesn't mean that we need to grow our team any more than we have now, because we are able to kind of decentralize and delegate responsibility for improvement across the whole organization. The drawbacks of that are that this has been a lengthy journey for us, and Hannah will talk about the journey, and I will as well, about how long it's taken for us to co-design this and how we've started to build this kind of QI culture in the organization. And you can see some other challenges there as well, like time and attrition. And so this is what it looks like from an organizational perspective, the independence model, the model that we want to shift to in CLCH, and have started to do so. The blue images there are showing all of the people and services we have across our organization. It's complex. This imagery is complex. It gets much more complex when you actually do it in practice, because we have 4,500 staff. And the ambition is that every one member of that staff and our patients are doing improvement work every single day. The baseline was that not many people knew about QI, or those that did were very few and far between. And we knew that we couldn't do this kind of training where we trained all 4,500 staff in advanced methods of QI, because that wouldn't be good return on investment. So what our trust did is that we, as many providers have done, is we established a central QI team. And that brought in-house expertise to be able to provide on-the-job support to people through training and through bottom-up support to be able to enable staff to be able to tackle the problems that they face. The challenge is that we have a very large and broad remit of supporting building a culture of continuous improvement, and we're also supporting key improvement priorities as well as bottom-up improvement. And we realized that as, again, the demand for QI increased, that we needed to do something differently. And so we looked out to our colleagues who are passionate about improvement and recognized that we could do more to foster their abilities to support staff to do improvement work, to be improvement coaches or quality coaches. And so now we have people across all of the organization, a friendly, familiar face who is there to provide that local support as and when people need it. They're also an advocate and a champion for QI, often endorsing it in every single conversation that they have. But how do we get there? How do we establish quality coaches? Well, that's where the Quality Coach Development Programme came in. And my boss, Jem, who's on the call and spoke earlier, did a bit of a piece of research and scoping, looking at the lie of the land about how we might do that in CLCH. And he recognized that there were many different programs already out there, but there were many barriers for CLCH to access those. Primarily cost. They cost several £1,000s per person, and we were looking at training maybe 100 or so of our staff, as well as geographic barriers. This was before COVID, and so we were not able to travel up to the north of England to attend some of the training there. And so we decided that perhaps we need to do something differently. The landscape was very positive, though, in that we had a very large number of colleagues from across the NHS and outside who were very keen to fix this same problem that they faced as well. And so we decided to join forces and put forward a bid to the Q Exchange programme, which is a funding programme housed by the Q community. And through that, we were able to receive some funding to then initiate our co-design of a new programme, which is the Quality Coach programme. And in those first discussions we had as part of that co-design, we asked the obvious question, what is a quality coach? And the answer came through from those discussions and is shown on the screen. It's someone who has a passion for QI. They've got the QI bug that we talk about. They understand the value that QI brings, and they're a champion of QI. And with passion comes experience. They have experience of QI work, be that QI project or continuous improvement work or any other improvement work. through their past. Importantly, the co-design group agreed that they needed to have dedicated time in their role as a quality coach. So they couldn't just go through some training program and then be left to support colleagues. We knew that they needed some investment in terms of their resource, in this case time, to be able to do that. And so CLCH had a very constructive conversation, and we realized that these staff need around half a day a week to be able to meet their requirements of a quality coach. And so that often means working with teams on local problems as well as key improvement priorities and QI training. On that note, coaches train, and so we thought that it was important to develop their skills as a teacher of QI, because so often in coaching conversations you do that just-in-time teaching where you show someone a tool and then they apply that tool. So we made sure that there was space for people to practice that in a safe way in our program. We've already said that coaches are champions of QI and they are advocating and promoting it in every avenue that they can. And that's really important for them to bring that passion out to their colleagues as well and spread that QI bug that I just mentioned. The name is, there's a hint in the name that they coach, and so they develop and nurture relationships based on trust and support, as well as building independence so that they can slowly step back from the teams and the colleagues that they're supporting as they kind of familiarize themselves with the QI process and the QI tools and techniques. And importantly, they're the go-to person for other things as well, like advice and support and encouragement. As I said, this was a conversation that started right at the beginning of that co-design, and you can see the timeline for the co-design on the screen here, right from August 2019, when GEM submitted the bid to Q for the funding. And after that, we had that design group, and then COVID hit. And we had to really rethink the way that we were going to tackle this problem, because we couldn't just get people in a room in central London anymore. It actually was an enabler of this process because we were now able to reach across geographies that we never could before. And so we had people coming from not just London or the south of England, but also from the north of England, Wales, Scotland, and Ireland. So we were able to reach out to people who we never had conversations with before. And through that, we started to develop and create a skeleton for this program. And we tested and iterated on that skeleton several times. So we piloted the program. I will admit that the first time we delivered the program, Jem will agree with me, when we were teaching it, it was a bit of a winging it thing where we did have 10 days of program content, but we did need to flex and adjust because we realized that the flow didn't work or things weren't as good as they could be. All of that learning was then brought forward to the next iteration, and we tested it 5 different times with a few different changes before we moved on to a very significant overhaul of the content, which was the image shown on the top right here, which is the program redesign, which Hannah will talk to you more about.
Yeah, so as Sid said, in autumn 22, we started a big program redesign. So doing a systematic review of all of the content that had been pulled together so far as part of the program. So this was not only all of the slide sets, all of the activities, the work, but that had been developed, and turning this from something that was obviously tested, reflecting on the learning from all of those pilots, but also turning it into something that could be picked up and become an off-the-shelf product rather than kind of something that obviously lots of people were involved in, had been quite close to it when they'd been testing it, I guess. So it was, that's been a really long journey. That's when I started to be involved, to come up with what is going to be a final product. And then after that, February, we started working with some designers who were going to kind of turn those products into something much better than what we could have created without them. We had a kind of redesign group in February where we came together and we came together and we found came up with like a vision, I guess, with the designers for what that final product would look like. Sorry about that. And those things are all coming together and they are going to be finished in August, so this summer 2023. Thank you, Sid.
Thanks, Hannah. And I think, this has been a labour of love, as I said. It's also been quite taxing and quite challenging at times. So although my reflections have been overwhelmingly positive, there are, of course, in any co-design, a lot of challenges. We've had 23 organisations contribute and 36 different individuals from our latest count. And so, of course, sometimes that can bring a lot of expertise and a lot of scrutiny and also a lot of challenge. I think the things for me that made it work the most were that we had a shared purpose. We knew that we needed to tackle a problem that we all faced, and perhaps sometimes we had disagreements about how we might do that, but overwhelmingly it was that we wanted to do something positive for our organizations and systems. We had CLCH kind of held the ring on this program, and so by doing that we had a small group of decision makers and conveners who were able to push things forward, to help chase people and to help kind of cajole people sometimes into helping us even when they're very, very busy. And we knew that we shouldn't ask too much of people, so we asked them to bring their expertise and the things that they were most passionate about to the program and not to bring everything. And that by that we created something that I believe was extremely high quality. The things I would do differently, and I'm sure we would all do differently if we were to do this again, is that we would call a camel as soon as we see one. So that old saying of a camel being a horse designed by a committee, where we were initially creating a bit of a monster program. It was initially 10 days, it's now 8 days, and actually we've said that actually 6 of those days are core and 2 are supplementary. So we've really slimmed it down and tested it and refined it, because we had all of our different PET methodologies and tools and techniques. And if we included all of them, it would have been, a 365-day program instead. So we call it as soon as we see it now, and that's really good. And people appreciate that, because instead of them running away and doing something and that not then being added in, we now make sure that is only used when it's needed. And I think for us, which celebrate our work more, this has been a really positive experience with many thousands of hours put into the co-design. And I think if we were to do this again, we did shout out about it a lot, and obviously we went to the HSJ Awards, but I think we could do that even more and give more and more congratulations to people.
So now I'm going to talk a bit more about what the product looks like at the moment. So as we said, it's a kind of off-the-shelf product, something that people are going to be able to access, download and then use within their organizations, within their contexts. So these are some of the things I'm going to go into a bit more detail. So there's 4 slides for all of the days of the teaching, and those are with slide notes. Along with that, we've also got some activities to kind of consolidate the learning, and to make it a bit more interesting when people are going through, so it's not just all completely people speaking at you the whole time. There's also lots of guides. I'll go into more detail about the guides, but we've got a trainer guide. So if you were part of the kind of faculty that might be delivering the training, applicant guide if you wanted to apply for the program to become a coach, the evaluation framework to work out how do we know that this program is good for not only the organization, but for the people that are actually on the program, and then a program leader guide, which is kind of a how-to guide of how you might run the program within your organization. And there's also a workbook for applicants with kind of extra supplementary material. So all of these things will be available to everyone that wants to carry out the program. They are, however, copyrighted. So it needs to be attributed when used. But however, they are also editable. So we wanted to make sure that we created something that people could bring their own kind of skills and expertise to. So the slides are editable. People can bring in their own examples. If someone's not on mute, can you please be on mute whilst I'm speaking? Thank you.
Yeah, Hannah, I could hear that too. Make sure we're all on mute if it's not Sid and Hannah at the moment.
Thank you. Thanks for that. Yeah, so we want people to be able to bring their own kind of skills and expertise to enrich the program, so that it's not something kind of static. So we want people to be able to use, for example, in the slides, this is a bit of a closer look at the slides, we want people to be able to bring their own insights and examples and adapt it to the context in which people will be kind of receiving the program, whether that's system-wide or in certain organizations. So this is some kind of examples of the lovely slides which the designers have obviously helped us with. And they come with full slide notes, so everyone, if you're teaching it, you've got the kind of support of the slide notes to deliver the program. This is some kind of screen grabs of the workbook. This has not yet been redesigned by the designers, as you may be able to tell, but the workbook is for the applicants, so provides a bit more detail about some of the tools and techniques that we use, and is kind of, I guess, a bit like a Bible, following the structure of the program as you go through it to become a coach. This is the program leader guide. So this would be for someone if you wanted to deliver the program within your organization. It's kind of a how-to guide of how you might go about that. So who might you need to involve? Who would be a helpful sponsor? What other people might you need to be able to talk to do that? And what's kind of the scope and how are you going to measure those outcomes as you go through? And that's a how-to guide for doing that. We've also got a trainer guide. So this is to support people who would be on the faculty delivering the training, delivering the teaching of those 8 days that we've come up with. So it talks about what support might need to be in place for the people on the program. And then for each day, I think it's on this slide, it's got full kind of what might you need to do before that we carry out the day, what would you need to do afterwards, what are the learning outcomes, and a detailed schedule of how that would run and how you might facilitate any activities as well. And the activities, we also have full templates that we've come up with. So these are on an online whiteboard and they're adaptable so that you've got the kind of full support of everything that we've tested, that we've carried out. All of the learning has come into this product, and then we've provided all of the detail, the kind of detail for people to be able to run it. So the program, this is the kind of overarching structure of what the program looks like. So it's 8 days. We've come up with these 4 at the top. We've come up with these 4 modules, I guess. And it incorporates lots of different fields, reflecting on the learning that was carried out during the pilots. These are the most important things that we think a coach needs to be able to know to effectively coach within their organization. So there's lots of different fields, thinking about improvement, change management, measurement, the psychology of change, human factors, and lots more. And there's an expectation that they'll have kind of support from a QI team or similar, and also actually start coaching whilst they're still on the program. So to get that kind of actual experience while still having the support of being within the program as well. So we've also got some outcomes, because we are obviously saying this is really great, but it's good being in QI to have some measurements to actually prove that. So some of the stats, 100% of attendees so far would recommend the program to a colleague and agree that the learning will be useful for them in the future, and have said that it enables them to coach improvement work, which is obviously really great. This graph here shows it's a self-reported ability for people to be able to carry out kind of key coaching skills, I guess, or key coaching tasks. You can see this was from the 2021 cohort. So we asked them before, during, and after the program to rate their own confidence in carrying out these skills. I can't read it because it's really, really tiny, but I hope that you can on my. So there's a good improvement there, which is excellent. As Jem said earlier, we've now trained 3 cohorts of coaches in CLCH. So that means that our capacity to provide QI coaching support has increased by 50%, because those people are actually able to carry out coaching as well as the QI team. We've also looked at outcomes in terms of improvement. So do coaches actually bring value? And we've seen an increase in positive sustained outcomes in QI work. So looking at projects which have a score of 4 or more using the IHI assessment framework. So in 2021, we had 6 projects which scored 4 or more. And in this year, we have 26 projects which score 4 or more. So that's a very big increase. May not be completely attributable to the coaches, but because there are other variables, but it's a good stat nonetheless. And also, we've had lots and lots of interest from other providers who want to adapt the program and use it in their organizations. So 34 people have expressed an interest to carry it out in 2023 or 2024. And if we equate that to some of the other programs, the pre-existing programs, which obviously you do have to pay for, this is a cost reduction of roughly £2 million a year if all of those organisations were to actually carry that out. So that's the statistics of why we think that the program is really good, proving that, I guess. So if you would like to find out more about the program, there is a special interest group on the Q community, so you can join that about coaching improvement, and there will no doubt be lots of discussions because the program is going to be launched hopefully in August. So there will definitely be more discussions around that. If you work at CLCH and you would like to become a coach or interested in the program, then please contact the QI team at this email address and we'll be able to support you to do that. And if you work in another provider and you're kind of interested in running the program in your organization, then let the QI team know here, get in contact with us or join the Q group as well. You can use the email again to get in contact. And then we just wanted to say a really big thank you to everyone who has been involved, who has helped support delivering the program, running the program with the redesign, it's been a really long journey. So we wanted to make sure that we thanked everyone, and it's been funded by the Q community and CLCH. So wanted to say a big thank you to them, and also the fabulous design agency listed here, Studio Quercus, who have been supporting make all of the resources look incredible. So thank you.
Thank you, Sid. Thank you, Hannah. It's clear that having a quality coach as a frontline member of staff, whether clinical or non-clinical, and is skilled in QI methodology and coaching is a really good way of helping colleagues to run their QI projects and to spread that knowledge and learning. So I'm quite convinced about this as being a good way forward. I'm also really impressed that 23 organisations and 36 individuals, not alone from CLCH, but across the country, joined in with this. And I think that's a real testament to how useful this is. And may I just touch back to say how useful it's going to be to that national programme, to know that there is this community already developed and available, because we're going to be able to make, as a group, a huge contribution to the national programme. Carlis, I think there were questions coming in, but we are running a bit late. So I'm wondering, can they be gathered up for the expert panel session? What do you think?
Yes, absolutely. That was my suggestion, was going to be my suggestion. Sid has already answered some of them, but if we need to, we can come back to them during the panel session. Just want to read out a massive thank you from Jem to Sid for leadership of this program and all the team and partners who have made this possible. And I will join Jem saying that it has been a privilege to be part of the process.
Great. And I think thanks absolutely to Sid and Hannah from everyone who's on the call. And we will pick up any questions that haven't been answered in the chat when we get to the expert panel. But first of all, we're now going to hear from a QI project supported by a quality coach that has led to positive changes in the way that the service works. And I'm going to hand over to Michaela Johnson, Service Manager, Brent Children and Young People's OT Service, and Joe Conway, AHP Student Facilitator from the Academy, and they're going to take us through this project. Thanks.
Hello, I'm Michaela, as Angela just said. So I signed up for QI Fundamentals because I recognised that there was changes that I wanted to make in my team, service improvements, and I didn't really know how. So I signed up for the QI Fundamentals course, and from there I then participated in the QI Practitioners course, where Joe was my coach, was assigned my coach. And together this was our first project as practitioner and coach, which was really nice, I think. And our journey began with a patient-initiated follow-up project within a sensory pathway within my service. So our journey began, like I said, with the sensory pathway, and the aims of this project was to, rather than hold children on a caseload after attending our sensory workshops, we'll introduce a patient-initiated follow-up model We'd create a new discharge process that enables the team to clearly discharge patients, free up resources for people who need it, but still allow patients to come back to the service should they need it. So we're freeing up patients while still allowing a quality service. And we collected service user attendance and DNA or was not brought data to support our project. And at the end of the sensory workshops, we have two. The therapist running the workshop will explain the PIFU process to the parents, and the parents will be informed that they have a 2-month window to call back for further advice and support. And if they don't call back, then they would be discharged. So patient-initiated follow-up, what is it in a nutshell? So it gives parents, their families and patients and carers the flexibility to arrange their own follow-up appointments when needed. So NHS England and NHS Improvement is supporting providers to roll this out. And PIFU is used with patients who have long or short-term health conditions in a broad range of specialities, including paediatric services. So this isn't a new concept. It's gone by many different names over the years, including open access for follow-up, patient-triggered follow-up, patient-led follow-up, supported self-management follow-up, and many more. So this approach assists with empowering our patients and their families to manage their own conditions and plays a key role in enabling shared decision-making and supported self-management. So PIFU has also been named as a part of the outpatients transformation required laid out in the 22-23 operational planning guidance, and also as a key part of the NHS's response to the COVID-19 pandemic. So PIFU helps providers and systems manage waiting lists and enable the patients most in need to be seen more quickly. So we noticed a few challenges that existed with the previous sensory workshop pathway. So what we noticed was children were remaining on the caseloads not being seen. For whatever reason, there were a high DNA rate of parents not attending the workshop. People would get into a DNA loop where they would be invited to a workshop, they wouldn't attend, then they'll be invited to another workshop, wouldn't attend, and so on, and they just kind of kept on going round and round in circles. We also had parents who were ringing our admin team, experiencing difficulties accessing the Microsoft form link and not being able to attend the workshop, and the admin team were getting overloaded with phone calls on the days that the workshops were run. And some parents were wanting to bypass the workshop and go straight in for an individual assessment. So what we did, so this was kind of this project opened the door for many other QI projects in my team. So what we found out that we needed to map our pathway, where we found out a lot of the problems, but then we discovered we actually had to process map all the pathways within my team because they all sort of link in with each other. And this is how we could find where we needed improvements and initiate transformation. We reinitiated the was not brought policy across the team in a uniform way and demonstrated how the OT team were integral to lower the discharges. With the DNA loops, we discovered through the process mapping that the loops were created through the DNA process. So we initiated text messages at different points in the treatment cycle and collected data to reflect the was not brought after the change. So then that made the team more confident in following a clear discharge policy, not only for the sensory workshops, but within other pathways within the service. To tackle the difficulties with the MS Teams link, we created a crib sheet for parents to join Microsoft Teams and emailed this to parents a day before the workshop with a direct contact. So rather than them calling the SPA, the admin team, they could have a direct contact for the occupational therapy assistant within our team who could directly help them with the link. And since we did this, we've only received one phone call through the SPA, which is really good. So now they're calling the admin, but with the crib sheet, we're getting less and less phone calls, which is really good. So the redesign and improvements around the sensory pathway, this is therapist-led with a clear process that parents understand, and they now understand the PIFU process and why it was implemented. So if we go to the next slide, so this is now what our pathway looks like. So within this, we have, if they, they identify that they need to attend a workshop, then the next step is they attend the workshop for the parents. If they DNA type once, they'll get a non-attendance, and we'll follow the was not brought policy. So as per our was not brought policy, to was not attend, then they'll be discharged. And then after they attend the second workshop, again, we could have the same DNA loop at this workshop. So at this part of the workshop. Then after this, they have 8 weeks to phone in to say they would like further support. So then from there, we could, depending on the needs, offer them a face-to-face assessment, provide telephone advice, or the parent won't contact us, which will lead to discharge. And this pathway is now working really well. And we have cleared up the caseload for children who do need it, but also parents are calling in if they feel they need it. So it's a win-win for us, really, I think. And then the next slide, please. So in this project led on to a lot more projects within my team. So this, can we go to the, I don't know if this slide is working. I'm stuck on slide 80.
Yeah, I'm on 80 as well. It's just moved to 81.
Oh, thank
Michaela.
you. So this is my team structure. So we have me as the service manager, then 3 leads for the 3 different pathways within my team, and then 6s and 5s, and then an assistant. So this structure is how we run our service, and we have 3 main pathways with a few pathways on the side. And from here, I don't know, Jo, if you want to take over from this point.
Okay, thank you, Michaela. So even though we'd done the PIFU project, we did think about what can we do to initiate QI improvement into the OT service, including the whole of the team, because even though they were participating, we decided that we needed to map the whole of the clinical pathways for the OT service, including the preschool pathway, the school age clinical pathway, the education, health and care pathway, to involve all of the therapists that were listed on the structure. Our approach that we used was some team away days. So we had 2 half days and a full day. And the process mapping meant that we could look at all the steps and the processes within a clinical pathway, identifying areas of duplication, improvement, and re-evaluating our processes that were there. We mapped this together as a team and shared our ideas, and found that this was a very defining moment. As the approach that we used was, we empowered the team. All suggestions, barriers, enablers and issues were valid, and everything got written down and put onto the process maps. And we decided we'd think about what a gold star OT service would look like. But also the therapy team started to realise that using QI process, that we could create change that would be sustainable, and we could start to test our ideas to see if they were viable. And the feedback that we got from one of the members of staff, which we felt particularly valued, was this is the first time that my ideas have been listened to. So we developed a Gold Star Service mission statement, or this is part of our SMART aim. So what we would like to do in Brent for the service is champion the role of OT by providing a flexible, timely, family-centred service that we are proud to represent. We will be supported in our learning and development. And this is some of the work that was done on that day by the therapists within the team. So we also looked at driver diagrams. We've just given you a little snapshot of this. So some of our primary themes, like how we would champion OT, the places we work, how we would improve our work, how we'd focus on the team to look at their health and well-being, their CPD and personal development, what we would look at around clinical admin processes, schools, staff and parents, and how all of this was identified and put into a mural board, and then we identified what is known as the ideas that we must do, that we could do, and that we should do. And these are themes that we're still working on at the moment.
So these are the change ideas that we have initiated from our away day so far. So we have created patient feedback forms for all our workshops and groups that we run to get feedback to make more improvements. We have started doing coffee mornings within our school service. This is so our SENCOs, or our special education needs coordinators, know how we work in schools and how they can easily refer into our service. We've also audited our GAS goals, which is goal attainment scale, which is what we use in therapy sessions. And we've aligned this with clinical pathways, and moving forward, these are going to be reviewed, audited quarterly. So we've also set up drop-in sessions for parents where they can call the OTs, who are the OTs for their children, within the school service to get updates on their children. So we are also currently working on another project with Health Matters to make OT accessible information on the internet, so parents can be sent a link to, for example, how should my child hold their pencil, or how can we teach my child how to tie their shoelaces, so they can access videos on the internet. We've also done caseload management mapping, mapped our clinical pathways that we've said. We're also collecting data, but my service moved from System 1 to EMIS at the end of March, so we're still figuring out how we can collect data from EMIS moving forward. And we've also reviewed admin processes, time versus need, and what do we need to do for that. And also we are currently reviewing our EHCP quality assurance processes, and we've embedded QI into our whole team, and basically everything we do, it's now from a QI perspective. And I really do think we do have a cultural shift within the team. Now that Jo said everyone can, everyone's views are valid, and we listen to everyone and take on those ideas, which is really nice. Also, with Jo's help, we've also restarted having students within our team, which again is really nice. Also looked at our triage process, and people are now taking ownership of the pathways, because there's now a clear processes for people to follow. And now we're doing away days with a QI focus. And with our supervision templates, we've added big sections about health and well-being, which is really good.
Thank you, Michaela. So just to let you know a few of our future change ideas. So we are looking at the educational healthcare needs assessment. We want to improve how therapists fill this in and how to improve their understanding around the processes. We also want to improve communication with the MDT and look at how contracting with parents and schools can be achieved, so we understand our responsibilities for each person around therapy, and responsibilities for both parents and schools and therapists. Also looking at how we can create accessible information for parents that come in more than one form, in terms of leaflets, video and audio, to make things easier. And looking at discharge change and how we can create a positive graduation to this. So episodes of care are clearly defined by the service, and accessibility to the service is explained to parents. So we have a transparency in our operation of service and what expectations will be. We've also identified leadership opportunities within the team, and how the team can take ownership of the QI projects, and that includes all bands, and some of our reflections around the project. So the scope of the project has been quite large, and Michaela and I have been meeting once a week for 12 months. At the beginning, we started to map out the process, and this enabled us to plan for the scope of the project, and it's still ongoing. We both completed QI coach and practitioner programs around this project. We've had support from the QI coach program, the QI leads, the data analyst in the team. We've had support from June Keogh, we've had support from Sid Beach, we've had support from Jem as well. We feel that we've created an environment to enable teamwork for quality improvement, and that we've got continuous improvement embedded as the team now understand what we're trying to achieve, but also recognition from the heads of clinical service, Kim Lewis, and recognition from the practice development AHP team manager, Denise Meredith, because that's part of the team I sit in. They allowed and recognised the importance of QI work, so they could allow us to work collaboratively. And also, as Michaela said, that was that was a good point for me to also reintroduce AHP student education into the team and connect with also other teams within the Chalk Hill site as well. So going onto site did add that extra dimension. So it would mean I could go and meet the physio teams, the speech and language teams, and it meant that relationship building was a lot easier on a face-to-face basis. And also, I think this week we've got another member of our QI team who will be coming out to teach fundamentals to the whole team. So with that, we'd just like to say thank you for giving us the opportunity to present our ongoing project.
Thank you.
So, Michaela, Joanne, thank you so much. I think what you've shown us there is that with the investment of time, the passion, the belief, sticking with it, that you really have been able to demonstrate you're changing the culture and that you're sharing that with others. And I think that is just such a powerful, powerful lesson. So thank you again for that. Are there any questions specific to Michaela and to Joe that we need to pick up now, Collis or Hannah?
There aren't any in the chat, no.
So we'll think that people have picked up as they've gone along and dropped any comments in. If no questions, can I invite you to thank Joe and Michaela again? And then we will move on now to our expert panel. Last part of the conference, important part, and I think we can probably dedicate 20 minutes to the panel, maximum, I guess, to answer questions about what you've heard. Now, people have picked up some of the questions during the day, but I know that Hannah and Carlos will help field some of those questions to the team. So I'm going to leave that with that group and come back into you later. I'm here watching, but I'm not going to lead the questions. Okay. So we've got Elizabeth, Carleen, I've now seen, Jem and Sid. Welcome, panel. Your questions are coming your way.
So if anyone's got any questions, oh, we've got one from Helen. So either pop your hand up or put it in the chat now and we will pick it up. So question from Helen, how can clinicians carve out time to do QI projects? Who would like to take that one? Elizabeth?
I'm happy to start. I think it's really challenging, and I think you do have to look at the circumstances of your team. I think part of this is the cultural shift, that investing time in this is time well spent and isn't taking time away from clinical care because of the rewards that we'll pay in the longer term. But just as that presentation that we've heard, it does take a cultural shift. I also think we have to be realistic about some pressures that some of our teams are under. And the really difficult stress that is caused by really large vacancies and turnover in teams. And that's why I stress that that is our improvement priority for this year. We do have to fix that because it is a kind of fundamental problem. We do have to have enough staff.
Thanks.
Having said I won't be part of the panel, I wonder if I could just add to that, because what I think we also heard very strongly in the last presentation was for the patients and their families, because they happen to be kids as well. Things were not going as they should. So you can keep investing in doing things that aren't working, or you can invest time in making it work. And I think what they showed is tipping that balance, because what is it? If we keep doing the things we've always done, we'll only get what we've always got. And so that investment of time probably has tipped the balance, Elizabeth. That's just my observation.
Yeah.
Oh, sorry, I switched off, Jim. Yeah.
Thanks. So I was just going to add, I think one of the real challenges is there's never time, and that's a perennial problem. So I think how that plays out is you end up with problems that you have to deal with, and we spend an awful lot of time firefighting. And this really comes down to a choice: is are you happy spending your time firefighting, or would you rather try and remove those problems at the root? And that's really the key to this, is no one's going to make time for you. You have to try and find a way to make time for yourself. And that is not, as Elizabeth said, not an easy thing to do. But if you don't make time in your week to have a conversation about what those issues are, why they're happening, how you can resolve them, we aren't actually going to ever do anything about them that's really going to stick. And I think that's really the key message is for all of us, especially for leaders, is we have to create the space for conversation. We have to create the space in our working week to have that conversation. And if we can't create the space, we can't really be surprised if we aren't improving, because that is the only way that this happens. And whilst recognizing making time for anything is incredibly challenging when you're stretched and you've got staffing vacancy issues or sickness problems or increased workloads, it's really thinking about, well, what's the bare minimum amount of time that you could make? And I think when we've seen this work well in other organizations, you can often have maybe just a 10-minute stand-up meeting at the very start of a day, where you just say, well, what's the problems that we're trying to tackle today? What should we do about it? Who's going to do what? And that's it. And then you're off and you get into your day job. So it's not impossible. I think the trick is knowing what to do with the time. And that's where the training becomes a really crucial element of how to do this well, is if you are confident and knowledgeable in how to do that, you use your time really effectively, and therefore you've got the discipline and the know-how to use a small amount of time to a great extent. So I think that's really the key to my answer, is get trained up, find out a bit more about how to do QI well, and then really challenge yourself to think, where do we need to have that conversation? And if you can't find time, you're not going to improve, is my answer. I hope that helps.
Thank you, Jim. Next question from Abigail. What would you say have been the biggest barriers to building capability within CLCH? Go ahead, Jim.
Right, I'm going to attempt to answer this one succinctly, but I've been here about 10, 11 years now trying to build improvement capability, and it's been a really long and really interesting journey that we've waxed and waned in many different ways. And there are so many different barriers. I think that's the real challenge to it. We've got huge number of things that we have to deliver. Patient care is the overriding priority. The systems change constantly, and creating time and headspace for improvement is really hard. And that is ultimately the challenge. So a couple of things that you really need to get over before you can do anything about properly building capabilities: you absolutely must have board commitment. We learned that the hard way, trying really hard. We did some brilliant training. We trained loads of enthusiasts. They weren't allowed to use their skills because that wasn't how we worked. And that really requires the leadership to change. So that's the first thing you've got to overcome, is if your board aren't signed up and your senior team aren't advocating this, then it's never, you won't succeed. And that really came through with the Health Foundation paper on the improvement journey, saying, don't skip to step 4. Start with step 1, which is get your board on board. And then really thinking about where are you focusing your improvement work. So if you have 100 things on your list of to-dos, don't add more. Start thinking about where is it appropriate to use improvement skills and improvement methods to tackle those priorities. And then, like we were saying earlier, think about how you can train teams. because training teams who are working on a priority challenge is one of the best ways to build that capability and embed it in a sustainable way. So I think those would probably be my top 3 tips. I think there are many more. We've got many years of experience, and I'm always happy to talk about them, but we just don't have time now. So I'll leave the floor to anyone else who wants to add to that.
Further questions? I wonder whether Colleen or Sid wanted to add, actually.
No, that's okay. I'll go to the next question, which is, if being a QI coach is not in one's job plan, it can be difficult to get permission from managers to do this. So what can be done?
Is that for me?
It's for whoever would like to take it. Yes.
Yeah, Carleen, please join in. So I think for me, when people enroll on the program, the first thing that we should say is that you do get time to be a coach as part of your job plan. And obviously for that to happen, we need to have a conversation with managers and leaders wherever you work. For us, the way the process works in terms of identifying who is eligible to be a coach or interested in being a coach, because we run cohorts of the program every year, is we look to our divisions and ask them who is kind of on your horizon, who is in your kind of field of sight, who might be eligible or interested in being a coach. And the best way for you to kind of be in the mix is to make your passion for QI really clear. So, practice what QI preaches, do improvement work wherever you work, involve the QI team, work with us. There's always opportunities to come and work with us to do whatever things that we do, like facilitation and teaching and coaching. And when you make that passion clear, for me, that's always been the best case for someone to be a coach. And the most important thing, and I saw another question in there around how do you convince and get people interested in the program? We don't have to. That's the thing. People come to us. There's so much passion for improvement in CLCH, and so we go where the willing are, and we go with the willing and their motivation and their passion. Colleen, didn't know if you had anything else to add.
Yep, you just said the last bit for me. I was going to say about interest. I think that the enthusiasm shows, people see the enthusiasm that people have for QI. I think that if people are showing an interest in QI, try to look to see what's available in terms of the training to really reinforce their enthusiasm with some real learning. I think, but by it being self-elected, I think actually that really feeds into their passion, and through that they're able to look for quick wins within the areas that they work in. Then other people are able to see the spread of that improvement, and that actually builds the momentum for people talking about QI and talking about the training that is offered. Jem?
Yeah, and I'll just say there's one other, massively important element, which is senior leadership. If your senior leadership don't support it, it's going to be incredibly challenging, and I think that is the bottom line. So we are incredibly fortunate to have such a wonderful and supportive senior leadership team here at CLCH that have enabled us to do that. And I know that isn't the case in every organisation, but I think if you are one of those leaders, then I think that is one of the questions you need to ask yourself is, how can you make that commitment to your staff to create the space to allow that development and nurturing of the culture to happen? And if you're not, then do look out there. There is some great literature out there. I think with the first document that we looked at was the building capability review. I don't know, Sid, if you're able to put the link in the chat. That's kind of the first one that came out that talked about the role of the quality coach and suggested having that protected time. So again, a really great place to start is to say, look to the guidance that's already come out and try and help get some support if you need it from others who have done it. And you'll see the examples from like East London Foundation Trust, where this is making a huge impact, and they're national exemplars having done this and embedded this and can demonstrate the difference that it makes. And we're slowly getting there ourselves to be able to do that as well. So I'm going to keep quiet now and see if there's space for more questions, but I hope that helps.
Thank you, Jem. We're going to go to Carol's question next, which is, given all that we've heard this morning, which has been fascinating, what would the panel say are the top 2 or 3 critical success factors in ensuring QI is embedded in the DNA of our organisation so that it truly does become the way we do things around here? So maybe we could go to Sid for that, if you would like to.
Yeah, of course. I'm sure
Yeah.
all of the panel will have their own thoughts on this. So it was the 2 to 3 critical success factors that help to embed QI within an organization, making it the DNA. I think for me, leadership and role modeling is one of the key factors. And, you know, if we're in a space where people are working towards performance management and firefighting, and we don't give ourselves that space, as Elizabeth said, that space and that time that we need to invest to be able to improve, then we're never going to be able to get there. And so it is almost a leap of faith sometimes, I've often found, with senior leaders, where we're asking them to trust me and to trust this process and to trust QI, that actually by spending some time away from the day job, looking at the issues that we face and using QI methods and other methods, that will fix this, and actually the return on investment will be significant. So for me, I'll pick one, and I'll probably the easiest one, so apologies to the rest of the panel. I think it's leadership and role modeling that is really critical to the success of embedding QI in the DNA. I'll hand over to Carleen next.
Brilliant. I want to go next just in case. So my thing would be patience. I think that, you know, like to create real sustainable change takes time. And I think that there has to, like Sid said about trusting the process, there has to be patience in making the change and not expecting everything to happen tomorrow. You know, like we talk about the plan and the Plan, Do, Study Act, really taking that time to plan what you're going to do next. So I think that my top thing would be having patience and trusting the process. Elizabeth?
Yeah, I think the one that I would really like to highlight is making the time, not just for the QI, but the sharing of the learning. And I think it's a particular challenge for us here at CLCH, just because we are so dispersed. And there is huge value in just hearing what other teams are doing and having those discussions, sharing the ideas, stealing the ideas. It's fantastic, but it's very difficult to find time in the day to do that. Technology helps because it means that we don't have lots of that traveling, but sometimes coming together face to face has got a kind of a different sense to it and you get more from it. But I just think we really do need to invest time in sharing, and then sharing externally as well. But we've got a really rich tapestry within the trust. We should make the most of it.
I'm going to jump in. I promise to keep it short this time because I can go on for a while. I would just say one of the things that have resonated the most in the 10 odd years that I've been trying to help introduce QI at CLCH is that HSJ Health Foundation article on the improvement journey. I think it really highlighted all the pitfalls and kind of cul-de-sacs that we went into. And it laid out a really important approach that I think if you follow it, and that is the way we've been following it, it's starting to make the difference. So I think that would be a really kind of a top tip for me is go and find it. I think we'll try and find the link and put it in the chat for you. But it really does resonate with what works. And it's, you know, I'm sure it's been based on some great research. So that would be my top tip.
Thank you, everyone. Do we still have time for more questions?
I would say one more. I was just about to say if we can do one more.
Okay. There is one from Jacqueline asking, how have you effectively engaged with teams across large geographical boundaries?
And that almost flows on from what Elizabeth and Jem were saying. So has anyone got on the panel got a kind of really crisp example of that?
I'll go. I think we just heard one from Michaela and Joe, where, you know, we had just adopted. So for those that don't know CLCH, we're a community provider, a very large community provider in London and Hertfordshire. And we had just had a large borough, a couple of boroughs join our organisation quite recently. And obviously that's quite a difficult time and a very strange time for people. And at that same time, we saw Michaela's service not only kind of excel, but, you know, embed QI as part of the day job and start to see that as the way things should be done. And I think that the way that was done is that we had a champion in Michaela, and we had that wraparound support from Joe Conway, the QI coach, to be able to support that. So I think for me, it's having people who can champion it and who really get it and going with that energy and giving them what they need to do that. So I'm really impressed by Michaela and by Joe. And I thought that was a really nice example of that.
Last comment then from Elizabeth.
Yeah, I mean, it was really just to stress the value of the collaboratives that we've had. We had 2 on joy and work and now another on health inequalities. And what you've got is teams coming together. They're working on different things because they're working on their own local projects to address local issues, but they're sharing skills, knowledge, experience, and that richness really helps. But that is across our geography, Hertfordshire, 11 London boroughs. It's a huge geography, but people are coming together, sometimes in person and possibly more frequently virtually, but it's great.
Okay, well, thank you all. Thanks to the panel, thanks to the people who facilitated, and thanks to the questioners, because I think even though we kind of struggled a little bit with time, we've actually been able to cover quite a lot of material. So Sid, Carleen, Jem, Elizabeth, thanks a lot for all that you've been able to contribute at the end of our morning. Now, Louis, we were going to have a word cloud, but I don't know whether we can or not at the moment. What do we think?
I would suggest, rather than doing the word clouds, if colleagues and friends on the call today could maybe send one word to describe today's conference. How did you guys feel about it? What's the sort of emotions that you're feeling? Any kind of reflective words that kind of spring to mind?
What, and just pop them in the chat?
Yeah, pop them in the chat. That'd be great.
Good, good. So
there's going to be...
Yes.
Sorry, Angela, I was just going to say that there's an evaluation form that's going to be sent out as well in the chat. So keep an eye out for that as well. And give us your honest feedback as well on how today has gone. And we'd love to hear from you as well and keep the conversation going.
Thank you. And I was going to remind people about the evaluation form, and you've done it beautifully. Thank you so much. And words are coming in. Words are coming into the chat. So keep them going. Keep them going. Just to say from me and really on behalf of all my colleagues in the leadership of the Trust, we have invested a central QI resource, and it's enabled us to build significantly, not just in CLCH, but to build as part of that bigger community. But I think probably, and Jem reflected this, we had a few false starts on the way. I think everyone does. And we found a way forward now that I think is going to work really well for us. But from all the people I've ever met in my working life over the last several years who embarked on some of these journeys, they still regard it as not having arrived. It's always a place they have to keep travelling. But the learning from each other and the learning from the leaders who've gone before us, I think is really important. And what we're doing, which I think is incredibly important, we're showing that for a community health provider. So that's a real strength for CLCH. So I just wanted to say that I think I want to thank all of the leaders you've seen, Elizabeth, Jem, Carleen, Sid and others. But also, can I thank the people like Hannah and Louis and Carlis and Jennifer and others who've put on this event today, because I think in the face of a few tricky bits at the beginning of the morning as well, they've actually provided us with a really lovely, strong, passionate, inspiring, there are my words, morning. So thanks to everyone for your efforts. And I do reiterate our commitment to continuing the QI journey. I don't think that James was able to rejoin, but certainly from Carol and I, thanks from the board as well. And have a good rest of your day. And we'll close the conference. Thank you.
Thank you.
just repost the link for the evaluation form? I think it might have just got lost in the chat. Might be helpful for anyone who's still hanging around or recently left to be able to do that.